So, okay na? Hello? Okay. Pero, mamaya pa to. Wala.
Merciful Lord, as we bow our heads in prayer as one community, we consecrate ourselves to your holy name. As we pursue our mission in healthcare and service for humankind, help us practice our subspecialty with concern for others. Serve every patient with utmost respect and compassion. Seek first the whole good of our patients, refusing to be influenced by any incentive. Share our knowledge and skills with our students and peers. Model in us what it is to be a good physician, striving hard to be the instrument of your healing power. Anoint us to conform to generally accepted scientific precepts and ethical principles. Never harm, degrade, humiliate, or exploit any person, whether a patient, a trainee, a pharmaceutical representative, or a fellow healthcare worker. Anoint us to work for the upliftment of public health and the socio-political conditions where infectious diseases can be controlled and moral lifestyles for all can be promoted. Give us the courage to do what is right and true, preserving in your love and believing in your justice and mercy. We ask that you bestow us your blessings and guide us as one community, dedicated to you as the true and ultimate physician. We ask this in your mighty name. Amen.
Which is that the world may live and see. Good afternoon, ladies and gentlemen. I hope you can hear me. Good afternoon, colleagues and fellow members. Welcome to the 42nd Annual Convention of the Philippine Society for Microbiology and Infectious Diseases. I am Dr. Pamela Ferrer, a member of the Board of Council and your chair for the opening ceremonies. This is our first virtual annual convention of the Society and our golden anniversary since PSMID was established in 1970. It is only befitting that as a society, we celebrate this year, even though the pandemic continues. A lot has happened since February of this year, since the Philippines had its first case of SARS-CoV-2. We must celebrate life, strengthen our relationships with one another, continue with our education, and give thanks to God and our fellow doctors who passed away as we persevere in our battle against COVID-19. The organizing committee for this convention has prepared an excellent scientific program to help strengthen our knowledge and skills in battling COVID-19. Without further ado, I would like to introduce our 2020 president. She is a beacon of leadership, competency, light, and hope in the midst of the chaos of the pandemic. Let us all welcome Dr. Marisa Alejandria, our 2020 PSMID president, to give her opening and welcome address.
Thank you, Pam. Dear PSMID members, friends, colleagues, and fellow health practitioners, a warm welcome to this momentous 50th anniversary convention of the Philippine Society for Microbiology and Infectious Diseases. First, join me in giving praise and gratitude to our Lord God for the continued strength, protection, guidance, and wisdom, for giving us provisions to allow us to organize this 42nd PSMID Annual Convention on the 50th birthday of our society. We also take a moment to remember our colleagues and modern heroes who have passed on, most especially our dear Ma'am Sally Gatchalian, past president of PSMID, and a staunch advocate of immunization and childhood TB. We celebrate and thank God for her life. This year's theme, Expanding Horizons for Gold, I'd like to think it's providential as the global pandemic drove home emphatically the point that the battle against COVID-19 and other infectious diseases is won not just at the hospital front lines, but rather it requires a whole-of-society approach. 2020 started with much optimism and excitement. Then, we were challenged by an unprecedented pandemic, which gave rise to chaos and uncertainty. But at the same time, it's giving us valuable lessons on adaptive collaboration, creativity, critical thinking, and effective communication. This anniversary celebration is dedicated to each and every one of you who are doing their share in this ongoing battle against COVID-19. My utmost gratitude goes to all of you as we all work together and continue to do so at the forefront against this novel coronavirus. Indeed, we have to expand our horizons as we strive to a new and adapt to a new and better normal. As a professional and academic society, our foremost obligation is to render optimal quality service to our patients and countrymen, to guard science and evidence through critical thinking, guided by the principles of ethics and equity. I salute the hard work and efforts of our organizing committee, led by Dr. Veglor Maginsay, Janice Kawili, Pam Ferrer, and Carl Henson in preparing this virtual conference. Our scientific committee, ably led by Dr. Nina Berba, has designed a holistic, exciting program for all of us, covering the science of COVID-19, its collateral effects, and the equally important socio-cultural aspects of the pandemic. Thank you very much, Nina and team. We also feature our partner organizations, the Philippine College of Physicians, Philippine Hospital and Infection Control Society, SHIP, Sustained Health Initiatives of the Philippines, and the HPAC, the Health Professional Alliance Against COVID-19. In celebration of the golden birthday of our society, I invite all of you to attend and engage in the workshops, plenary lectures, industry symposia, research forum, COVID Chronicles that our scientific committee has prepared for you. And on Saturday, we invite you to celebrate virtually with us as we reminisce the 50 golden years of PSMID. Thank you to Dr. Mafi Taizon and team for organizing our gala night. Let us celebrate with the spirit of hope and love in our hearts. Let us all be responsible for each other and be responsible stewards of the planet we live in. The convention is now officially open. Enjoy and keep safe, everyone.
Thank you so much, Dr. Alejandria. Thank you, Dr. Alejandria. To give us an overview of the 5 days of the convention, may I call on Dr. Veglor Maginsay, our overall chair of the organizing committee of the 42nd PSMID convention.
Dr. Marisa Alejandria, President of the Philippine Society for Microbiology and Infectious Diseases, members of the PSMID Board of Council, distinguished speakers, honored guests, colleagues, ladies and gentlemen. Today, I am privileged to welcome all the participants to the 42nd PSMID Annual Convention. Thank you for choosing to spend your valuable time with us in the next 5 days. This year's convention is special since we are also celebrating PSMID's 50th anniversary as a society. And unique because for the first time, the convention is taking place on a digital platform. The organizing committee has done its very best to develop a convention worthy of your time, despite the limitations and difficulties. Every year, we have a theme. This year's theme is Expanding Horizons for Gold, PSMID in the Forefront Against COVID-19. The scientific committee likewise has prepared a well-balanced program of both scientific and non-scientific sessions relevant to the topic of focus in this convention, which is COVID-19. We have invited prominent speakers, local and foreign, who will share their expertise and experiences on the diagnosis, management, and control of COVID-19. Notice that all scientific sessions are in a plenary format. This is intentional to enable us to maximize the learnings we can have through these sessions. 5 minutes is allotted for Q&A after each lecture. You can forward your questions through the chat box, and the moderator will present the questions to the speaker. We hope that this conference will benefit not only us, but also the community we serve as well. Day 5 is PSMID Day, which will now be devoted to the celebration of the golden years of PSMID. We invite all our speakers, sponsors, and registered participants to celebrate with us. Listen to our esteemed past presidents, Dr. Angeles Tan Alora and Dr. Mediadora Claudia Saniel, who will deliver the Dr. Elpidio Gamboa and Dr. Bienvenido Alora memorial lectures, respectively. During the grand ball, have ready your wine glasses, filled with wine, of course, as another past president, Dr. Jaime Montoya, leads us in a toast. I wish everyone a safe and a fruitful convention. Thank you.
Thank you, Dr. Maginsay. Thank you, Dr. Maginsay. Now, may I call our Board Secretary, Dr. Janice Kawili, to present our new fellows for induction to society.
Good afternoon to everyone. I am honored to present 13 PSMID members who have fulfilled the requirements for a fellow member. To be a fellow member, one should be a diplomate in good standing for at least 2 years and has been recommended for fellow membership by at least 2 fellow members in good standing. Our PSMID members who will be inducted today for fellow member are Dr. Joanne Bonaobra from the Bicol Regional Training and Teaching Hospital, Dr. Marja Buensalido from the Medical City, Dr. Inofel Chin, who's now practicing at the Southern Philippines Medical Center, Dr. Adrian Hieronimo, now at the Benguet General Hospital, Dr. Jelly Ann Gozon from St. Luke's Medical Center, Quezon City, Dr. Ayla Halothot from the University Health Service, Los Baños, Laguna, Dr. Noreen Kansi, she's now at Cotabato Regional and Medical Center, Dr. Eileen May Lee, now practicing at Davao Doctors Hospital and Southern Philippines Medical Center, Dr. Adelaine Lopez, she's now at St. Luke's Medical Center, Global City, Dr. Ana Flor Malundo at the Philippine General Hospital, Dr. Peter Ravian Senyar, he's now at Marikina Valley Medical Center, Dr. Yvette Silubrico from Iloilo Doctors Hospital Incorporated, and Dr. Roland Sara, he's now practicing at Ilocos Provincial Hospital, Gabriela Silang. May I now call on Dr. Marisa Alejandria, our president, to conduct the oath of membership for our new fellow members. Thank you.
Raise your right hand and follow after me. I state your name. Having been accepted as fellow member of the Philippine Society for Microbiology and Infectious Diseases, Incorporated,
the Philippine Society for Microbiology and Infectious Diseases Incorporated,
hereby solemnly swear
hereby solemnly swear
that I will faithfully discharge
that I will faithfully discharge
to the best of my ability
to the best of my ability
the duties of the position,
the duties of the position,
that I will observe and support
that I will observe and support
the organization's constitution
the organization's constitution,
and that I impose the obligation upon myself voluntarily
and that I impose the obligation upon myself voluntarily
without mental reservation or purpose of evasion.
without mental reservation or purpose of evasion.
So help me God.
So help me God.
Congratulations to our new PSMID fellows and welcome to the society.
Thank you and congratulations to our new fellows. Thank you, Drs. Kawili and Dr. Alejandria. This year, the Accreditation Committee had its first virtual visit and accreditation of a training institution. May I call Dr. Cherry Abu to present the recognition of accreditation.
The Philippine Society for Microbiology and Infectious Diseases, at the forefront against COVID-19, now more than ever, is committed to train infectious diseases specialists who will respond to the healthcare needs of the Filipino people in the management, prevention, and control of infectious diseases with dedication and highest standards of care. Despite the challenges of the pandemic, this institution has satisfactorily complied with the prescribed standards and requirements for fellowship training program in infectious diseases. Ladies and gentlemen, we are excited and proud to award this plaque of accreditation to the 7th Training Institution for Fellowship in Adult Infectious Diseases. The Medical City. Congratulations!
Congratulations to the Medical City Fellows in Training and the consultants and the training corps. In this opening ceremonies, we would like to pay tribute to our past president, Dr. Salvacion Gatchalian, who passed away this year. Together, let us celebrate her life and achievements. Thank you very much to the UP-PGH Fellows for preparing Dr. Salvacion's video. So that wraps up our opening ceremonies. May I now call Dr. Yvette Barez, past president of PSMID, to introduce our plenary speaker.
Good evening to our distinguished guests, colleagues, ladies and gentlemen. Welcome to our 42nd Annual Convention. It is with honor and pleasure to introduce our guest speaker for the first plenary session today. She is an infectious disease epidemiologist that specializes in emerging infectious diseases and is based in the Health Emergency Program at the WHO. She is the technical lead of COVID-19 response and the head of Emerging Diseases and Zoonosis Unit at WHO. She was the head of an outbreak investigation task force at the Institut Pasteur Center for Global Health in Paris, France from 2006 to 2008. She conducted a field research into surrounding zoonosis, respiratory viruses, emerging and re-emerging viruses such as Ebola and Marburg. She worked as a senior research fellow in Medical Research Council Center for Analysis and Modeling for the Imperial College of London from 2009 to 2015. So please help me welcome our distinguished guest who will talk on the transmission of SARS-CoV-2. Can we end the pandemic? Dr. Maria van Kerkhove.
Thank you so much for the kind invitation and the warm welcome. And it's such a deep pleasure for me to be with you today. So good morning, good afternoon. I'm going to share my screen. That's okay. Can you see that okay?
Yes.
Okay, wonderful. So thank you again for the invitation and to speak with you today, and congratulations to all of the awards that you just presented. So I'm going to spend the next few minutes talking a little bit about the global pandemic and what where we are, and really where we're going. What is the plan for bringing this pandemic to an end? And I will start off by saying that we will end this pandemic, and we will end this pandemic with the tools that we have now and with the tools that are coming online in the very near future. So let's start with just an overview of where we are. So the current epidemiologic situation is presented here on this slide. And what you see here is the epidemic curve broken down by WHO regions. You can see the regions down in the bottom left-hand corner. There are some key dates that are presented on the epi curve when WHO took some initial actions upon first learning of a cluster of pneumonia of unknown etiology from Wuhan authorities on the 31st of December. Within hours of learning of that, we activated what we call our incident management team. And this is a team of WHO staff who are part of our headquarters, our regional office, Western Pacific Regional Office in the Philippines, and our country office in Beijing. And this was activated immediately upon learning of this cluster that was picked up through our epidemiologic intelligence from open sources platform, which identified the ProMed article describing this cluster. And this incident management team initially activated to be able to pull together available information to provide to our member states and contact points and publicly about the ongoing situation, which we issued our first alert on the 5th of January. At the same time, while we were gathering information about the cluster itself and really understanding what the extent of infection was, what the disease it was causing, how it was potentially spread, we were developing our first technical package of guidance. Within this guidance, which was issued on the 10th, the 11th, and the 12th of January, we included surveillance guidance on who to test. We issued guidance on which samples to collect, upper respiratory and lower respiratory samples. We issued guidance on infection prevention and control, guidance on how to protect health workers and those who are collecting samples, and how to protect the virus from spreading between people. And we issued a guidance around clinical management. And this was rapidly developed because we were able to adapt existing materials that we had for MERS coronavirus. Knowing that this was a coronavirus, knowing that this was causing respiratory illness, we could quickly adapt the materials that we have and made publicly available to all of our regional offices, our country offices, and publicly. And as you know, we held 2 emergency committee meetings on the 22nd, 23rd of January, and then again on the 30th of January, when WHO and our Director General, Dr. Tedros, declared a public health emergency of international concern. Now, this is the highest level of alert under international law, called the International Health Regulations, that WHO has to raise that alert. And what you can see on the 11th, now on the 30th of January, there were less than 100 cases and no deaths reported outside of China. We described the situation as a pandemic on the 11th of March. We had been talking about it for quite some time between the 30th of January and the 11th of March, warning the world, to take action, to get their systems ready. We issued a series of other guidance materials to make sure that the countries were prepared to receive cases. What was really incredible was the fact that the full genome sequence was shared on the 10th, the 11th of January, and within 2 days of that, we had issued a blueprint of how to develop PCR assays, and we had done that with our partner laboratory in Germany. This is Charité University. And from that, we were able to work with companies to rapidly develop PCR tests, which we began shipping around the world the first week of January. And that really allowed the world to be able to detect cases. But as you can see on this epidemic curve, the situation has really tragically unfolded across the world. And to date, we have more than 62 million confirmed cases globally and more than 1.4 million deaths. And this is data as of yesterday. But if we break it down, there's quite some differences around the world. We do a weekly summary every Monday where we look at the trends over the previous 7 days, and then every day we look at what has happened in the 24 hours preceding. And what you can see in the last week, we had almost 4 million cases reported. The week before that, there were just over 4 million cases reported. And we do see a slight decline in the global trend, but that's largely driven by declines in many countries across Europe. The countries on the right are those that have the highest number of new cases reported in the past week. And you can still see that the countries with the highest number of new cases, the US, India, Brazil, followed by a number of countries across Europe and also Iran. And then you can see the total cases per million population. And it varies quite drastically region by region. So let's look at that region by region. These are the epidemic curves by WHO region, and you can see different patterns here. One of the most striking things that you can see in Europe, and if you can see my cursor here, this first peak in the spring in Europe, for example, was a very large peak. And what we're seeing here in this second peak is quite dramatically different. But what is likely have happened here in Europe is that because testing was so severely limited in Europe, this peak of cases was probably much higher in the springtime. But we did see a number of countries really bring that transmission to a low level. If you look at Africa, this epi curve that you see here in the middle on the bottom is largely driven by the epidemic curve in South Africa, which had a big outbreak and brought that under control. And we really do see some different patterns across the world. Next are a series of maps looking at cases reported in the last week per million population. The darker colors indicate a larger number of cases reported per 1 million population. And in fact, we had to actually update these maps and change the color coding because we were seeing such large numbers of cases reported in some countries. And you can see the darker red indicate more cases. The next slide is looking at the percent change in the last 7 days, with the dark red seeing an increasing trend. Now, some cases that had a small number of cases would have a large percent change if that percentage doubled, for example. And this is looking at the percent change in deaths over the last 7 days, where we see in the darker red is a higher percent change. But if we look at the globe overall, it's very difficult. I get the question a lot of what is the global situation? Can you briefly describe what's happening across the world? Well, it's actually quite difficult to do because we see very different patterns and situations that countries are facing. We describe these as follows. In some countries, we have low reported transmission. They kept it low, and in a sense, the outbreak never had an opportunity to seed in these countries. And many of these you see in island states. We have a number of countries that had a single peak, So you have one peak and then they've been able to reduce transmission and keep it low. We see some countries that have a single peak, but they see continuous transmission where we still see an exponential growth. We've had some countries that had an initial peak where they brought under control, and now they're seeing a resurgence in many countries as control measures have lifted. And then we have countries that are seeing multiple resurgences following reduced transmission. Give you some examples. So for the low reported transmission, many small island nations and many countries across Africa and WIPRO have really seen this, and they've done a very good job at preventing the virus from taking hold. Many countries across the majority of the African region have seen a single peak and seen reduced transmission, and right now they're seeing low levels of transmission where they've brought the virus under control. We do see some countries that are in a single peak continuous transmission where they've had significant transmission for at least 3 months. And there are many countries, which I showed you on the initial slide in that top 10, that are really seeing this. And then we have many countries that have seen, a large proportion of the European region have seen peaks and low level of transmission. They've seen resurgence and they've brought it under control. And these are all very difficult situations to be in because we're seeing quite a lot of fatigue globally. Well, let's talk about the WHO strategy. This strategy was launched on the 4th of February, 4 days after WHO declared a public health emergency of international concern. And this strategy has been outlined under 9 pillars of work. And the goal is and remains to suppress transmission, to save lives and to save livelihoods. And the way that we achieve this, and through all of our regional offices and our country offices, working with ministries of health and working beyond ministries of health to mobilize all sectors and communities to ensure that every sector of government and society has ownership, takes ownership of, and participates in the response in preventing cases through individual measures, such as hand hygiene, respiratory etiquette, and individual level physical distancing, to control sporadic cases and clusters, to prevent those initial cases in those clusters into turning into community transmission by rapidly finding and isolating and caring for all cases, providing appropriate care, making sure that we carry out comprehensive contact tracing, supported quarantine, making sure those that need to be in quarantine from others so that we can break chains of transmission are supported in that quarantine, making sure that we suppress community transmission through context appropriate infection prevention and control measures in medical facilities, but also outside of medical facilities. And in some countries, they have had to look at population level physical distancing measures or these stay-at-home orders, making sure that any restrictions on non-essential travel are appropriate and proportionate in terms of restricting domestic and international travel. Another objective is to reduce mortality by providing optimal, appropriate, rapid clinical care for those who are affected by COVID-19, making sure that we ensure the continuity of essential medical and social services. We've seen a dramatic impact on essential medical services, and making sure that we protect our frontline workers and our vulnerable populations. And then lastly, to develop safe and effective vaccines and therapeutics, making sure that they can be delivered at scale and making sure that they are accessible to everyone who needs this globally. And what you can see in our global strategy is that it's part mitigation and it's part containment. And I think in the beginning of this pandemic, many people thought you either had to focus on containment or you had to focus on mitigation. But really what we need and what we still need are elements of both, because this virus can be controlled with the tools that we have in hand now. So the way that we work is we are fully mobilized at all of the levels across WHO. We have 194 member states. We have presence in 150 countries with more than 7,000 WHO staff. And we work under our GPW, our Global Program of Work 13. And what we do is we work with partners to monitor the situation, to learn, to guide, to coordinate, to support, to communicate, to supply, to innovate, and to deliver. And I'll touch upon each of these. So in terms of monitoring, assessing, and informing, so we have 24/7 monitoring of the global, regional, and country situation. and we produce daily situation reports. We switched to weekly situational reports a few months ago, where we provide these online, which is an overview of what is happening in every country and what is happening regionally, as well as providing some summaries of some critical activities that WHO and partners are involved in. We are currently carrying out more than seroepidemiologic studies and severity studies in more than 60 countries, and I'll come back to this in a few minutes. And we were looking at more than 129 country, territory, key informant surveys to assess the impact on essential medical services and mental health. We continue to learn and guide. We have more than 20 expert networks which are gathering, assessing, and distilling scientific information, evidence-based information, and turning that knowledge into know-how, into guidance that is actionable and practical. We've issued more than 400 technical guidance documents, which have undergone a robust review process, which has been rapidly sped up because of the pandemic nature that we are in and the emergency nature that we are in, as well as hundreds of information products trying to articulate and describe very complex aspects of this pandemic around transmission, around severity, around immunity, to the general public, as well as to our scientific partners. And we have more than 140 courses available on our open WHO training platform, available in 42 languages, because we have not really been able to travel and do the in-person training that we would like. We've utilized and harnessed the web platform that many people around the world have access to deliver that training on a one-on-one basis. And we coordinate. So we don't work alone. We never work alone. We coordinate with our member states across the G7, the G20, the European Union, the African Union, and many others. We have weekly dedicated member state information sessions where we share information and we learn from our member states about the actions that everyone is taking to bring the outbreak under control. We have regional director engagement with our member states. We coordinate through the UN, through our crisis management team, which is led by Dr. Mike Ryan. And we have much partner coordination around GOAR and the Global Outbreak Alert and Response Network, our EMTs. We work with FAO, we work with OIE and others. So we are one of many partners coordinating the actions related to this pandemic. We communicate. We do our best to try to communicate the ongoing situation, answer questions directly from the media, answer direct questions from the informed public through global press conferences, through social media, Facebook Lives, and for example, we have an information network for epidemics, our EpiWin platform, in which we are training infodemic managers. This infodemic that we are all dealing with this barrage of information that has come to us, some of which is good, much of which is bad. Very difficult to manage all of the information and making sure that we have appropriate, accurate messages that counter the misinformation and the disinformation that is spreading. And we provide support. So more than 170 countries have strategic national action plans, which is based on our strategic preparedness and response plan, which I outlined a few slides previously. We have 146 countries which are using our COVID-19 partners portal. We have regional technical support missions to 106 countries, and EMT and GOAR missions and health cluster working in countries across the world. We've produced case studies in 59 countries to show how countries are using the SPRP to fit the needs of the country, the capacities of the country, the cultures, the preferences, in the situation. So each country needs to adapt the global preparedness plan into a national action plan and implement it according to the needs of the country. There have been 16 intra-action reviews, joint external reviews and living reviews, because as this pandemic unfolds, it's very important that everyone assesses the situation, assesses their response, and make changes accordingly. That is not a sign of weakness, that is a sign of strength, and using the data at hand to see what needs to be changed to really bring this outbreak under control. In terms of supply, more than 500 million items have been supplied to 180 countries. And this includes PPE, it includes diagnostic, it includes oxygen and biomedical equipment. And we work with a large number of partners to be able to deliver this, including the Global Fund, IOM, UNICEF, UNDP, UNAID, UNOPS. So again, we work with many, many partners. And we're really driving and pushing research and innovation. We developed a research roadmap in early February, involving the world's expert across 9 pillars of activities related to epidemiology, the animal-human interface, virology, infection prevention and control, clinical management, therapeutics, vaccines. And we've launched the Solidarity trial. And this slide, this image is a little bit old, but we have more than 12,000 participants from 500 hospitals that are participating in this global clinical trial looking at therapeutics. It's really unprecedented, the ability in this work in the middle of a pandemic. So the role that I have is I'm the technical lead, but I'm also our health operations lead. And what we do is I've outlined this part already, but what we do is our normative function is to develop policy and technical guidance. And so we work through international networks that are established by WHO that which are tailored now for COVID-19, but many of these networks were already established for MERS coronavirus, for SARS coronavirus, for influenza, for dangerous pathogens for the lab network and our GLAD-HP network, and mathematical modeling, statistics and mathematical modeling. What we did is very quickly in early January, we brought these groups together to exchange information. And one of the most critical examples was the initial discussions we had with clinicians and medical professionals who were treating patients in Wuhan, treating patients across China, speaking with clinicians in countries across Europe, across North America, across Africa, across South America, to have that immediate exchange of information and knowledge and experience sharing by frontline workers. And that ability to share that type of information is faster than any peer-reviewed publication, any report, any webinar that can be organized. And that really catalyzes that direct knowledge, pulling all of the information that we have on the day that we have it at hand. So we develop guidance. And one of the areas we develop guidance on, not just specific to the technical aspects like clinical management or testing, but we adapt that guidance based on the transmission situation scenario that the country is in. So we have this overarching chapeau document, as we call it. We lovingly call the 4 C's. And this describes all of the actions that countries need to take in this whole of government, whole of society approach. Critical preparedness, readiness, and response actions, depending on the situation, the transmission situation, which are defined as having no cases or no active cases, sporadic cases, either imported or locally detected, clusters of cases, and then outbreaks of community transmission. We recently broke down community transmission into 4 levels, from low incidence community transmission to very high incidence community transmission, or RCT4. And in this particular guidance, we outline, it's the closest thing that we have to a to-do list, which outlines all of the activities that need to be done, and then hyperlinks to the exact guidance to tell countries how and what they can do. But the way that we develop this is through science. And science is driving our understanding of how we develop what actions need to be taken. And from the beginning, if you heard any of our press conferences in the beginning and our public speaking, 2 of the key aspects that we were looking at and we continue to look at is severity, looking at the natural history and disease progression, looking at risk factors for severe disease and death, looking at recovery and long-term effects. And this is something we are beginning to learn about. We do not have a full picture of the long-term effects of this virus, of people infected with this virus, even people who have had mild disease, some people who have had asymptomatic infection. We really don't understand the full impact of this, and this is really quite worrying for us. Different ways to estimate mortality, and there are different measures of mortality. The case fatality ratio, which is very crude, because it's dependent on the number of cases that are reported, the number of deaths that are reported over the number of cases that are reported. A more accurate number would be the infection fatality ratio, which is the number of deaths over the estimated number of infections. And the estimated infection fatality ratio is around 0.6% overall, which is a lot higher than influenza, but it does vary drastically by age, and it increases dramatically by age. The other aspects that we continually look at are transmission. And what is really critical about transmission is not just the mode of transmission in terms of droplets, in terms of aerosols and fomites. It's about the location and the setting in which transmission is occurring. And what is really critical is about the intensity, the duration, and the context of the exposures. This transmission is driven by contact patterns. It's driven by close contact. And if you're in close contact with an infected individual, whether they have symptoms or not, the virus can spread. And some of that is spread through droplets, or they're all small particles. Some of these are droplets and some of these are aerosols in that close range. And that is really, really critical because there are actions that we can take to prevent that transmission from happening. But we do know that transmission can be amplified in enclosed, crowded, and poorly ventilated settings where the virus can become airborne. And that is really, really critical because, again, there are steps that we can take to prevent that from happening. We know that people that can transmit before they develop symptoms, if they don't develop symptoms at all, and when they have symptoms. From the data that we have seen, most people are most infectious about 2 days before symptom onset to about 5 to 7 days after they develop symptoms. And that makes control a lot harder. It doesn't make it impossible, but it makes it a lot harder. And it's very different than SARS and MERS, where people are most infectious, were most infectious for SARS, are most infectious for MERS later on in the disease course, when they're most often isolated already. We're looking at secondary attack rates and cluster investigations. And from the secondary attack rates in households, for example, we've seen these secondary attack rates in the range of 4 to 35%. And we know that people with symptoms transmit more often than people without symptoms. But again, we know people with and without symptoms can transmit. We're looking at the extent of infection as measured by seroepidemiology. I'll come back to this in a moment. We're looking at IgG, IgM, neutralizing antibodies, and also T-cell response. And we're looking at which are the at-risk groups and those with underlying conditions where there may be a higher risk of amplification. So one of the first things we worried about, and one of the first things I said publicly on January 14th was the worry that we had about super spreading events. For coronaviruses, super spreading events are a hallmark of the way that they behave. And we were worried initially that these would happen in healthcare facilities, but now we're seeing that there are super spreading events that are happening in a number of close settings, like long-term living facilities, prisons, expat dormitories. We are seeing some in healthcare facilities, but there are some estimates that suggest that 10 to 20% of cases are responsible for 80% of transmission events. That's really important because that means not all people are transmitting. It really is operating in a clustering way. And so if we can prevent that from happening, we can really take the heat out of transmission. And there's a lot of questions that remain about transmission among children. And we're learning that there are differences in transmission susceptibility to infection and transmission in children by age group, with the youngest children having lower levels of seroprevalence and transmitting less, likely driven by the contact patterns that they have. So if we look at the seroepidemiology, more than 300 papers, either through peer-reviewed papers, and sorry, that should be the end of November. There are more than 300 peer-reviewed publications, preprints, and government reports that are available. And most of these suggest that less than 10% of the population have evidence of seroprevalence. Most of them have been done in the springtime. We have very few that have results from the fall. But this indicates that the majority of the world remains susceptible to infection. And this is important because this means that the virus has a long way to go. And if we allow it, it will spread. We do see some individual studies that suggest that there's a higher transmission, that there's higher seroprevalence in areas that had higher transmission intensity or among frontline workers. But what we really would like to see are population-based, age-stratified studies that are looking at individuals over time. And what we would like to see is more evidence about what is happening now with seroprevalence. Is seroprevalence increasing? How long do antibodies last? And what does this mean for vaccination? if we look at immunity, there's a really nice figure on the right here looking at the differences between PCR positivity, antibody detection, and when people are most infectious. And this is it's a very nice illustration over time. But what we know about immunity is that about 90 to 100% of infected individuals will seroconvert within the first 4 weeks after infection, and that 90% of those seroconverted individuals develop neutralizing antibodies. We don't know how long these antibodies last. We don't know how long someone would remain immune, but there are some promising results that suggest that this is many months. We do have some clues from other coronaviruses that this will not be lifelong. And so we really need to better understand how long the immune response lasts. And it means that we will have to put in the individual measures for quite some time before we have the vaccine and while the vaccine is developed and rolled out. One of the things WHO is doing, while there are 300 papers published globally, they're very, very different. And they range in quality, they range in methodology, and they vary in terms of the assays that were used. So WHO actually more than 10 years ago developed these early investigation, these core protocols for influenza seroepidemiology studies, which outline protocols, core research methodologies for different types of populations for flu, which have been adapted for Zika, have been adapted for MERS, and have now been adapted for COVID-19, where we provide the methodology to countries, support them in carrying out seroepidemiology studies, and we're providing them also with serologic assays. And we have more than, it should be 60 countries that have studies underway that are carrying out one or more of these protocols, with an additional 40 countries that are working to implement these studies, 70% of which are in low and middle income countries. And you can see the countries outlined in green here that are carrying out the studies, and those in pink that are intending to carry this out. So there's good representation across the world. And what our aim is not only to build research capacities in country, but to be able to pool results using the same methodology so that we can come away with regional and global estimates of seroepidemiology for different populations. And so our health operations and our technical expertise teams work to develop, to consolidate all of this science and this evidence into practical guidance. We are constantly looking at all of our published materials and updating them. They're all living guidance, so they're under constant review and revision and updating. And we will continue to do so as new evidence is published and as needed. And we try to discuss this with all of our international networks. We do discuss this with all of our international networks. We have consultation with our strategic and technical advisory groups. We discuss through a global health leaders forum, which was established by the Director General, which represent individuals and global leaders from all over the world. We also discuss with our GORN steering committee, and then we publish these on our web. At the same time, we're working very hard to ensure that we balance the demands of the COVID-19 response with actions that can maintain and bring back online essential medical services. Essential medical services have been tremendously impacted because of the pandemic. So we not only need to save people's lives and prevent people from getting infected with COVID-19, but we need to ensure that babies are born safely, that vaccines for vaccine preventable diseases are provided, so that treatments for HIV and TB are provided in cancer treatments, and dengue and Zika and malaria, and so that we don't forget, and no one has forgotten, we need to get these services back online. And we're seeing good strides in bringing these essential medical services back online. So where does this leave us? A lot of people ask, now that we're almost a year into this, has the strategy changed? And it really hasn't. Our goal remains to suppress transmission, to save lives, and to save livelihoods. And the only way that we can do this is together. So we outline our actions going forward on this slide here. And 3 major areas of work are to suppress transmission, reduce exposure, so that we reduce transmission from happening in the first place. We need to prevent infections. We need to reduce mortality and save lives, and I'll come back to all of these in a moment. And really critically is to empower individuals, engage communities, and enable them to take action. It's one thing to tell communities what to do, but if we don't enable them to be able to carry out these actions, they won't be able to do so. And so what we've seen in a number of countries that have really had success, they've had their communities know completely, exactly, entirely what they need to do and understand that we all have a role to play. And all of the actions that we take on an individual level, at a family level, at a community level, at a state or provincial level, at a national level, at a regional level, at a global level, all matter. And all of these actions have positive and have negative consequences. So enabling and empowering individuals to know what they can do is really, really important. So let's talk a little bit about what works. We look at the first action around suppressing transmission to decrease incidence. What works are the following. Physical distancing of at least 1 meter works. This virus operates in clusters, and it needs people to be in close contact with one another. If we can ensure physical distancing, that will break chains of transmission. When we can't, wear a mask. And this is really important. We've seen a lot of good use of mask wearing, but that needs to be safe. You need to practice your hand hygiene to wear a mask, put it on and take it off appropriately so that you're not inadvertently infecting yourself if your hands are contaminated. Making sure that you have good hand hygiene and respiratory hygiene practices. The rapid identification of cases, contact tracing and cluster investigation with rapid turnaround testing, knowing where the virus is and taking appropriate public health actions where you isolate cases and you quarantine contacts breaks chains of transmission. We know that in some situations, countries that have had to use temporary and geographically targeted restriction of population movement, restrictions of social and mass gatherings have worked to prevent transmission, to prevent the spread of transmission. We know that timeliness in the speed of the actions related to these interventions, the quicker, the better. The more data informed, the more targeted and tailored the approach, the better. We've seen initially many countries had to do national actions, and now what we're seeing are sub-national tailored approaches based on the data, based on where the most intense transmission is. We need to protect vulnerable groups who are at risk of super spreading events, who are at risk of developing severe disease and death. We need to make sure that we engage communities so that they know what they need to do. And we need to lower the physical and financial barriers to access health services in the first place. In terms of reducing mortality, we've seen globally that trends in mortality have reduced over time. And this is for a number of reasons. First of all, we're preventing infections in the most vulnerable groups. And the most notable example of this are long-term living facilities. Once the virus enters, if the virus enters a long-term facility, we see devastating impacts with high amounts of morbidity and mortality. If we could prevent that from happening, and many countries have done this, you can prevent a large number of deaths. We know that early actions at the first point of health access drives initial evaluation of the patient, where the oxygen saturation is checked, an initial assessment is done so that they quickly know if the patient needs oxygen or mechanical ventilation. And we know that dexamethasone works for severe and critical patients. And this is a widely available drug that is inexpensive and accessible. And this saves lives if it's administered to severe and critical patients. We know that not only helping COVID patients, but ensuring essential medical services for other critical diseases continue for everyone everywhere, that saves lives, that reduces mortality. And again, allowing people, lowering that physical and financial barrier to access health services reduces mortality. In terms of empowering people and communities for action, listening to the concerns of population, engaging, responding actively and timely with accurate information. This does include not only discussions and direct conversations, but monitoring social media and engaging with prominent networks. We have an explosion of access to information. Again, not all of which is good information, and some of it is purposefully misinformation and disinformation to confuse. Making sure that we provide regular, consistent, and evidence-based information, which is adapted to various audiences, taking into account not only language, but culture and preferences and values, following risk communication principles and best practices, and making sure that we empower and engage the communities to develop contextualized situations to manage risk. We have, through our EpiWin platform, engaged so many different sectors: youth, religious groups, sporting groups, business sectors, travel and tourism industry, to engage, to look at the contextualized solutions that minimize the risk, that manage the risk, that reduce the possibilities for this virus to spread, while trying to get back to our quote-unquote new normal. And so our critical areas of focus are making sure that we have global collective action. This is critically needed to end this pandemic. We need strong, cohesive national leadership and implementation of all government and all of society plans. This leadership needs, and these implementation strategies need to be coordinated regionally and globally, using all available tools that we have right now to suppress transmission, to save lives, and to save livelihoods. There are many ways in which we can reduce and control transmission and prevent amplification events, which I've outlined before, but we need to enable and empower people to be able to carry out individual level actions, scale them up where needed, in terms of making sure that we have the public health infrastructure in place to detect cases, care for cases, isolate cases, ideally outside of the home, but if at home, safely, so that the virus does not spread between family members. And we do know that a lot of the transmission is happening, continues to happen in homes, which we've known from the beginning, which is why WHO recommends isolation of cases outside of the home in specialized facilities. And when that can't happen, safely done at home, away from other family members. To save lives, protecting vulnerable groups from getting infected in the first place, and making sure that we have rapid, high quality clinical care by trained, protected health workers. And to accelerate the development and access to COVID diagnostics, therapeutics, and vaccines. There's an incredible global collaboration and fair allocation framework that is in place. I'll come to this on the next slide. And making sure that we not only have safe and effective vaccines, but that they are accessible to those who need it everywhere on the planet. And we're working hard now to build vaccine acceptance, understanding of what vaccine and vaccination is, and preparing for vaccination campaigns. And so through the support we provide to countries, we still use an evidence-based approach for our recommendations to manage COVID-19. And we're supporting countries to implement this evidence-based guidance, making sure that it is agile, adapted according to the transmission intensity and the need. We need to strengthen health systems now. Even countries that are in intense activity need to scale up. Countries that have controlled COVID need to scale up now, need to scale up the workforce. And the countries that have had experience with SARS, with MERS, with avian influenza, with Ebola, with yellow fever, with cholera and meningitis and monkeypox, these types of infectious diseases have built a trauma in countries where they know that it's the workforce, it's the community health workers, it's the public health actions to identify, isolate, test, treat cases, trace contacts, quarantine contacts. This is what works for viruses like SARS-CoV-2. And this is what we need to continue to build. Make sure that we provide protected health workforce, making sure those supplies for PPE. We need all countries to advocate still an adoptive whole of society and a whole of government approach to ensure that we have these measures in place and to adjust them where necessary. And we need countries to share their experiences. So we are learning from each other about how to take a strategy with clear and on paper what look like simple actions, which are incredibly difficult to implement, and showing us how countries have done this. We need to learn from each other, and we will continue to learn from each other. And the way forward involves this unprecedented collaboration that we have across a large number of partners: FIND, the Global Fund, the World Bank, Wellcome Trust, UNITAID, CEPI, Gavi, WHO, so many others, which are working with governments, civil society, industry to ensure that we have rapid development of new diagnostics, novel diagnostics with quicker turnaround, therapeutics that are safe and effective and available, vaccines that are safe, effective, and available. We have a fair access and allocation program, and so that we ensure that everyone at risk has access to a safe and effective vaccine in all countries, as opposed to having the vaccine available for all people in a few countries. And this Act A, the Access to Tools Accelerator, was developed by WHO and partners in April. And this is what we are driving forward to make sure that these vaccines are delivered at scale across the world. I will end there, and thank you so much for the opportunity to speak with you today.
Thank you very much, Dr. Kerkhove, for very informative and very inspiring lecture. That we can end the pandemic. It's prepare, empower, and respond. This is a timely lecture because all of us wants to have a merry and happy Christmas. And fatigue pandemic has already set into most of our people. So we have a few questions in our chat box. The first question is coming from Dr. Janice Kawili, and she is asking about reinfection. Is there a criteria for telling a patient is having a reinfection or not? Dr. Kerkhove?
Yes, thank you. So yes, we have reports of reinfection. And the way that this is being reported to us is the labs that have been able to sequence the first infection and the subsequent infection have looked at the full genome sequences, and they've seen that the virus is different. And it is indeed a reinfection. We don't know how often this is happening. We do have reports from a number of countries, and after more than 60 million cases, there are definitely reports of this, so we know that it's possible. And this is something that we anticipated because we know that the immune response is not lifelong. What is really important for us to better understand are two things. One is, what is the immune response of these individuals following the first infection and at the second infection, the subsequent infection? And is this a situation where either the person didn't mount an immune response after the first infection, or that immune response waned or declined over time? So we're learning. We don't have the full answers of this yet. And the second thing that we're trying to get a better handle on is, what does the second infection look like? Is the second infection more mild? Is it more severe? And again, we're still learning about this. We do have one report of a death among the second infection, but many of the cases we have seen, the subsequent infection has been less severe. But again, I don't have a complete answer on that and cannot give a conclusive response, and we're learning. I think one of the things we need to be very careful about with this pandemic is really, in this virus, is to remain humble. Although, we know so much more than we did in the beginning, we don't know everything. And we need to make sure that we are open to learning and listening with information that's gathering. We anticipate there will be more reinfections. Largely it's being detected in countries that have sequencing capacity. It doesn't seem to be happening on a large scale, but it does tell us that it is possible.
Okay, thank you. We have a question from Angeline Torres. Do you have suggestions on how to handle disaster, man-made or natural management in COVID-19 facilities?
Is the question about disaster management in COVID facilities?
Yes.
So we have, I'm not sure if I'm going to answer the question appropriately, but what we have in a number of situations, we have outlined different ways in which the management of COVID patients in different types of facilities can be arranged, either through existing buildings and hospitals, to the repurposing of facilities, to building new facilities. We're working with countries that are dealing with not only COVID, but other humanitarian crises, natural disasters, and making sure that facilities are safe, that there's good patient flow, that the airflow system, the patient flow system is appropriate. We have set up a help desk. We call it our Health Ops Help Desk, where we receive direct questions from countries and we provide one-on-one system support to be able to help manage patients based on the local context and capacities and situations. So there is no one size fits all for everything. I mean, that's one thing that we've learned. We outline the different measures that need to be done, but there is no one size fits all. It really needs to be tailored to make it appropriate for the local context.
Okay, thank you. We have another question from Dr. Salido. Has WHO drafted a preliminary criteria to say that the pandemic has already ended?
Ooh, that's a good one. We get a lot of questions about like, when is the pandemic going to end and what about the next pandemic? I really want us to get through this first one. And what I would like to see is an emphasis on, in the countries that have controlled this virus, to bring it down, keep it down, and follow through. What is striking to me is there are dozens of countries now in every region of the world that have shown us that they can control transmission. If they let their guard down too quickly, it can resurge. But a number of countries across the Western Pacific, if you look at a number of countries in the Mekong Delta region, China, Japan, Korea, Australia, New Zealand, I'm gonna name some and I'm gonna forget some, and I don't mean to leave countries out, but they've shown us that this can be controlled. And we just need to follow through. Europe showed us this over the summer, and we relaxed, we let our guard down. But there doesn't need to be a resurgence. And I think that's what is really striking to me. There are criteria about when the pandemic is over in terms of describing it that way, but this virus will be with us for quite some time. I think what we will get to is a level of low-level transmission with outbreaks. In terms of, I don't see us eradicating this. I do see us eliminating this virus in many different situations, countries, regions, areas, territories. And the vaccine will be incredibly helpful for helping us bring that under control. But let's get through this one first.
Okay, we have one last question because we're running out of time. This is from Dr. Edsel Salvania. Excellent talk, Dr. Van Kerkhove. Thank you. Not sure if you are the correct person to answer this, but here it goes. How does WHO explains its baffling conditional recommendation against remdesivir, citing no good evidence when IDSA and US NIH guidelines recommend remdesivir in its guidelines with an A1 grade evidence from ACTT-1. So I think this is because we are baffled now whether to use the remdesivir or not.
Yes, so we have issued our therapeutic guidelines on remdesivir, and we've looked at a number of different clinical trials across the world. So if you look at that guidance material itself, we looked at the clinical trial data from the US, but also from the Solidarity trial and other trials as well. So we compiled all of that information from the trials, conducted a meta-analysis and looking at that. And that's why we had the conditional recommendation within the treatment guidance itself. But it is outlined in there. We will continue to look at clinical trial data as clinical trial data become available, and look at it in its totality across a number of different trials across the world.
Okay, that's the last question. Thank you again, Dr. Kerkhove. We are grateful with what WHO is doing in handling this pandemic, and good evening to everybody.
Thank you so much for having me, and good luck with the rest of the conference.
Thank you.
Okay.
The certificate of appreciation is being given to Maria Van Kerkhove for sharing the invaluable expertise as resource speaker on the topic Transmission of SARS-CoV-2, Can We End the Pandemic? It is signed by Dr. Reina Berba, Dr. Veglor Maginsay, and Dr. Alejandrina.
Okay. Hello, good evening. So we're going to start the second plenary session. After an excellent presentation, we expect another excellent presentation for our plenary speaker. Our second plenary speaker for this 50th Annual Convention of PSMID is Professor Leo Yee-Sin. She's an infectious disease specialist and the current Executive Director of the National Center for Infectious Disease in Singapore. Professor Leo has led her team through multiple outbreaks in Singapore, and this includes the Nipah outbreak in 1999, SARS in 2003, pandemic influenza in 2009, and multiple surges of vector-borne diseases, including the Zika outbreak in 2016. Most recently, she has successfully managed Singapore's first imported case of the monkeypox in May of 2019. She is also a multi-awarded individual, among which are the Public Service Star in recognition for her outstanding battle against SARS. Other awards include Excellent Star Award in 2005, Red Ribbon Award in 2014, and the National Healthcare Group Distinguished Senior Clinician Award in 2016. Professor Leo is also active in academics and she has an excellent achievement to this effect. Her key researches includes emergence of emerging infectious diseases, dengue, and HIV, and her recent focus on point-of-care testing attests to her work in improving patient care and outbreak control. She has more than 200 scientific papers. Ladies and gentlemen, please welcome Professor Leo Yee-Sin.
Good evening. I am Professor Yee-Sin from the National Center for Infectious Diseases in Singapore. It is my pleasure this evening to share with you this topic on inflammation's response to COVID-19. And I would like to thank the organizer for giving me this opportunity to be with you today. So thanks to PSMID Annual Convention. Today we have a look at inflammatory response due to COVID-19 or the causative agents called SARS-CoV-2. Now, before I jump into the topics, I would like to introduce to you the very new setup in Singapore, the National Center for Infectious Diseases, where I work. Now, this is a purpose-built infectious disease center, and its main responsibility is to be able to support the entire nations in outbreak response. So this particular center has about 300 beds that is scalable to about 580 beds within the building. It is a full-fledged clinical service building, inclusive of intensive care units, operating theatre, and other key facilities. And in addition to that, it has the National Public Health Laboratory with BSL Level 3 capability, together with the National Public Health Epidemiology Unit, as well as the ID Research and Training Office. So this relatively unique building or the center put together all these key elements to facilitate Singapore in terms of our response to outbreak. And now, obviously, we are still in a mode of COVID-19. And this center is just newly opened. We started operation end of 2018 and officially opened in September 2019. So I'm sure many of you would know where Singapore is. So if you look at the globe, you can see this red little circle circling these very small island states of Singapore. Let me give you an update of the COVID situations in Singapore. From the very beginning of the COVID outbreak in January to the middle of November 2020, the blue line represents the total number of confirmed cases, and the green line shows you the total number of cases discharged from the healthcare facilities. So as of now, middle of November 2020, we have had 58,130 cases confirmed with COVID-19. And of these, only 63 of them still remain in the healthcare facilities. So about 99.8% of them has been discharged. And we reported 28 deaths out of the 58,130 cases. And currently, we do not have any COVID-19 cases in the ICU setting. To give you the epidemic curve of the COVID-19 in Singapore, the top line shows you the cases that we detected in the dormitory. The middle portion shows you the number of cases detected in the community. And the bottom right shows you the current situations where we are facing with imported cases. So starting from March, here from this graph, you can see the red arrow showing you circuit breaker. And with the introductions of circuit breaker, we managed to reduce the number of new cases both in the community setting as well as in the dormitory setting. However, in the recent months, we are seeing more and more imported cases being detected in Singapore. So the bottom right shows you the imported cases from July to middle of November. So predominantly, the current cases are mostly imported cases. The table shows you the mortality rate. So in Singapore, our mortality rate is very low at the rate of 0.05%. COVID-19 was first described by China in Wuhan end of last year. And a lot of information then came out from the Chinese researchers, and this is one of the work that's been published in Lancet this year, looking at the experience, looking at the severe cases of COVID-19 caused by SARS-CoV-2. And here you can see the clinicians and researchers describe the critical illness of COVID-19. Many of these cases with critically ill conditions develop typical clinical manifestation of shock, including cold extremities and weak peripheral pulses, and yet in the absence of overt hypotension. And this is a term and hypothesis given by them called viral sepsis. They went on to put together the entire pictures with hypotheses explaining the clinical observations. And here from the diagram, you can see that the primary target was the lung, where the virus will then invade the pulmonary tissues and trigger off the cytokine response and giving you the typical clinical manifestations of shock-like clinical illness, leading to multi-organ dysfunction. And these pro-inflammatory cytokines and chemokines include the alpha TNF, IL-1, beta IL-6, as well as other pro-inflammatory cytokine. Now, these pro-inflammatory reactions then giving rise to multi-organ failure. So from this diagram here, you can see the suggestions of cardiac involvement, the liver involvement, the kidney involvement, leading to many patients succumb to the disease from multi-organ dysfunctions. Now, the author then proposed these conditions as to whether this whole bunch of pathological changes due to direct viral-induced tissue damage, or it is due to systemic cytokine storm, or could be a synergistic effects of both. Now let's have a relook into how human responds to viral infections. Now, this is a very simple schematic drawing looking at how we handle and invading pathogens. First of all, we have innate immunity, which is an inborn capability to fight against any of the invading pathogens. We need to have the integrity of epithelial barrier. We have many of the first-line defending cells to help us be able to defend against any of the invading organisms. Now, these include the phagocytes, including the dendritic cells, including the NK cell, as well as the complement. Now, innate immunity's response against any of the invading pathogen is almost immediate. So immediately, we trigger this response to protect us. And once we trigger the innate immunity response, and then orchestrate down to our adaptive immunity that will include our T cells and B cells with the productions of antibodies. Now, the antibodies typically became available around about 5 to 7 days, and the whole immune response against any infections is very well orchestrated so as we can achieve a balance and achieve the goal of eliminating the virus or invading pathogens. Now, this is a very nice schematic representations of what happens with the patients with COVID-19, the spectrums of clinical illness, ranging from asymptomatic clinical illness to symptomatic clinical illness that can be mild, can be moderate, and in some cases could be severe, critical, leading to some cases with succumb to the infections. Now, all these are basically depending on how the immune system responds to SARS-CoV-2. In cases that with mild clinical illness, they're able to balance the immune system and immune reactions leading to a good cytokine CD8 response, leading to the productions of good antibodies, as well as a good balance of a Th1 response. However, in unfortunate group of individuals where there is immune dysregulations, we will then experience acute inflammations with exuberant productions of cytokine, leading to lung damages as well as multi-organ damages and leading to severe disease that the patients can succumb to the infections. To understand the disease pathogenesis is always good to look into the tissue damages. And these are the post-mortem finding of the patients looking at the primary target of lung. So you can see there are significant damage to the lung with hyaline membrane productions with giant cells being seen in the histology finding. On closer look at the lung pathology, looking at the pulmonary and vasculature, again, you can see that there is interstitial and perivascular lymphocytic infiltrations in the lung. And in addition to that, you can see multiple microthrombi as well as multifocal endotheliitis. Now, this is looking at the ultrastructural features of the lung. And here you can see a very clear demonstrations of virons that being disseminated in the lung, in the alveolar space, as well as the extracellular virions being seen. And here you can see the viral particle within the fucosomes of the alveolar macrophage, as well as viron in hyaline membrane. So here, essentially from these histology findings, demonstrated the presence of the virus in the lung tissue. And again, the virons are also demonstrated in the upper respiratory airway as well. So we know by looking at this histopathology finding that it's direct viral invasions into the primary target organ. And we know today very well that COVID-19 is highly associated with coagulopathy. And again, looking at this electron microscopy, looking into the virus, you can find the virus particles and inclusion bodies are seen in the endothelial cells along the blood vessels. And here you can see the presence of many of the inflammatory cells within the capillary, as well as apoptotic endothelial cells with the presence of mononuclear cells. So again, showing you the direct viral invasions into the primary target site. Here is the endothelia, as well as the damages that it can cause to the endothelial cells. Now, again, this is showing you the venous thromboembolisms in the patients with COVID-19. Now, again, this features here showing you the lung damages, as well as a huge thrombosis in the vessels. In the gross histological pictures, you can see this pulmonary embolisms, as well as a deep vein thrombosis. Now, with observations from the histopathogenesis features, we need to put these observations, give it an understanding of the observations. This is one of the paper published by the eBiomedicines this year, and the author titled this paper as the 4 horsemen of the viral apocalypse, showing you the pathogenesis of SARS-CoV-2 infections. So here, a few key messages here. There is the dynamic interactions between these 4 very interacting 4 vicious feedback loop. And all these 4 components, in fact, are all happening at once. First of all is the viral loops, the virus invading into the primary target sites, eliciting hyperinflammatory reactions, disturbing the renin-angiotensin system axis loop, and leading to hypercoagulation loop. And all these are all happening all at once. Now let's look at the 4 components one at a time. Let's look at the virus component. SARS-CoV-2 has slightly different viral characteristic compared to the SARS in the year 2003. It has the ability to interact and downplay or upregulate certain immunological response. So first of all, the virus will have to gain access through the receptor, and here it uses the ACE2 receptors as well as the TMPRSS2 receptors to gain access into the infected cell. Now, once it gains access into the infected cells, in fact, it interferes with the innate immunity, leading to the downregulations and unchecked replications of the virus. And that is the reason why the SARS-CoV-2 virus can reach a very high titer at the very early phase of clinical illness due to these unchecked replications. And as the virus enters into the lower respiratory tract, it will have interplay with the pulmonary tissues. It eludes from antiviral effect of the interferon 1 and interferon 3, and it activates the innate response and induces the productions of cytokines. And this cytokine, in fact, is required for the recruitment of adaptive immunity. But in this case, it became an overdoing it with a hyper-inflammatory response. Now, this is a schematic drawing showing you the trajectory of two different disease manifestations. The top line showing you with a viral entry leading to a mild disease. The bottom line shows you the patients that develop severe disease. The bottom line shows you the different types of immune cells that will make up the entire human immune system. So we have B cells, we have CD4, CD8, memory CD8 cells, as well as the macrophages, neutrophil, NK cells, type 1 pneumocyte, as well as the type 2 pneumocytes. So let's look at this. When the virus enters into the lung, the SARS-CoV-2 virus will then get attached to the pneumocyte. And that will elicit the alveolar macrophage to now come in to interact with the infected pneumocyte. So this is where you see from here, in the patients with mild clinical illness that will recover, the macrophage will interact with the infected pneumocytes, and that will then trigger off the productions of the pro-inflammatory cytokine, and therefore this will then regulate the response of the adaptive immunity, elicit the productions of antibodies, bring in the cytotoxicity to be able to handle the infected cells. So from here, you can see the NK cell that is killing the infected cells. In other words, we are clearing the virus through the cytotoxic process. And with these productions of inflammatory cytokine, antibodies response, both innate as well as the adaptive immunity work hand in hand in a very well orchestrated, balanced manner with the aim to clear the virus with the productions of antibodies and the other arms of the adaptive immunity. Now, patients will recover because these patients would now have the ability to clear the virus and have the ability to produce antibodies for their own protections. Now, let's look at patients with severe COVID-19. Now, the virus attacks the pneumocyte, and with that, it elicits the immediate response with the infiltrations of neutrophil, with the alveolar macrophages. Now, the inability of the macrophages in handling the virus, allowing the replications of the viruses, as well as allowing the hyperproductions of many of the pro-inflammatory cytokine, and this is what we call hypercytokemia. At the same time, it's ineffective in bringing in the good adaptive immune response, leading to CD4 apoptosis, leading to reductions in proliferations and exhaustions of cytotoxic cells, inability to kill and eliminate the virus. And also there's ineffective productions of the antibodies. So all these giving rise to hyperproductions of hyperinflammatory cytokine. And with these hyperexuberance productions, in fact, cause multi-organ damages. And the patients may then have the persist virus shedding in patients with severe disease. This multi-organ failure, as well as coagulopathy, in some of the patients, it can kill some of the patients. Now we look at renin-angiotensin exists. We now know that SARS-CoV-2 require ACE2 receptor to gain entry into the host cell. With that, ACE2 down-regulations after SARS-CoV-2 induced endocytosis and then increased angiotensin II level, and that promote vasoconstrictions, inflammations, fibrosis. And this explain the septic shock-like symptoms where the patients could have cold extremities and extremity vasoconstriction. Next, we look at hyperinflammations and hypercoagulable states. The two diagrams here showing you the perivascular inflammations. You can see a lot of the inflammatory cells surrounding the vessels in both of the histology features. And in the clinical findings, this coagulopathy is manifested as elevations of fibrinogen, elevated D-dimer, and very minimal change in PT and APTT, and platelet count in the early stage of the illness. In many of the cases, you will see an elevations of IL-6 level that correlated with increasing fibrinogen level. And elevated D-dimer at admission is associated with increased mortality. I would now like to introduce to you some of the research activities and research outcome from our group in NCID in Singapore. We established this cohort we call PROTECT cohort, and with that we enroll patients with COVID-19 and follow them over a period of time, and this is a longitudinal cohort. With the establishment of this cohort, we can then study in depth disease transmissions, pathogenesis, looking at how to then develop diagnostic capabilities within using the cohort sample, and using the same cohort to look into vaccine development, therapeutic modeling, social behavioral and communications. So today we will talk more on how we leverage on the PROTECT cohort to further understand the COVID-19 pathogenesis. This work was published in the CID this year. Now, what we have done is to look at first 100 cases enrolled into PROTECT as a longitudinal cohort, and our intention is to follow them up to 2 years. And of these 100 cases, abnormal chest X-ray was found in 57 of them. 20 of them require supplementary oxygen for hypoxia, and 12 of them require invasive mechanical ventilations. And of this cohort, 3 have died. Now, from this cohort, we look into 3 groups. One group of patients without pneumonia, second group of patients with pneumonia, but there was no hypoxia, and the third group of patients, we look at those with pneumonia and hypoxia. Comparing those patients without pneumonia to patients with pneumonia but without hypoxia, the significant markers was that of an elevations of C-reactive protein as well as elevations of LDH. However, when we compare the group of patients without pneumonia to a group of patients with pneumonia and hypoxia, the most significant markers still the elevations of C-reactive protein as well as the elevations of LDH, a marker of tissue injury. And the other findings we can get from here is a significant reductions of lymphocyte, of lymphopenia, reductions of platelet count, but in fact, if you look at the range of platelet count in very severe patients, it is not significantly lower than many of the other viral illnesses. Other significant findings when you compare these two groups also include kidney injury with the elevations of creatinine and elevations of LDH suggestive of liver damage. And slightly significant number of them with a lower level of hemoglobin. And then we look into this cohort of patients with varying degree of severity, compared with the 23 healthy individuals. And the most important thing is to look at the panel B. Panel B shows you healthy control in this heat map compared to those patients without pneumonia, patients with pneumonia but without hypoxia, patients with pneumonia and with hypoxia. So you can distinctly see the difference between the groups. So for patients with pneumonia with hypoxia, you can see across elevations of pro-inflammatory cytokine, as well as elevations of the growth factor suggesting of lung injury. And the severity of the disease is highly corresponding to the level of the cytokine. So in other words, the higher the level of cytokine is the indications of a more severe disease. But it's important for us to then remember a very distinct difference between patients with pneumonia without hypoxia and patients with hypoxia. You can see from here, there is a very distinct elevations of pro-inflammatory response. And in the same cohort, we look at the serology, the antibodies response to COVID-19. The presence of antibodies in this cohort up to 1 month of the data collections. You can see the elevations of IgM, IgG, round about day 15 to day 21. So this is also something that we need to remember, that somehow in COVID-19, the antibody response seems to be slower than many other viral infections. We see a peak only somewhere around day 15 to day 21. And we look at the durations of viral shedding. We're also looking at gender as well as age. We did not find any significant difference in terms of the level of antibodies. However, when we look at the disease severity, comparing the three groups, we can see that patients with pneumonia and with hypoxia tends to have a much higher level of antibodies. I think this finding was also corroborated by many other studies as well. That is, the antibody level is highly correlated with disease severity. The more severe the conditions, the higher the antibodies. We then look into viral shedding and correlate that with the immune response in our cohort. And here we included the 201 symptomatic patients, and we look at the viral shedding. The mean RNA shedding was around 14 days. And then we look into individuals with intermittent shedding, about the 40% of them with the intermittent shedding of the RNA or detectable RNA through the PCR detection. And we look at those individuals with short durations of RNA shedding compared to those people who continue to have RNA PCR positive for a prolonged period of time. Here we use 14 days as our cutoff. And then we look into the immune response, and we found that the durations of shedding was inversely correlated with plasma level of T-cell cytokine, measured as IL-1 beta as well as IL-17A at the initial phase of infections. So this study suggests that early immune responses are beneficial to control the viral load and prevent viral RNA shedding. Now, this is a relatively complex study that we look into the immature neutrophil in patients with COVID-19. But I just want to quickly mention here that when you look at the IL-6 is closely correlated with the presence of immature neutrophil count as well as disease severity. So IL-6 and IL-10 in our cohort are two of the key biomarkers that we see that correlate with the disease severity. Now, with all these informations, we come back as a clinicians to ask ourselves in terms of how can we apply these informations into clinical management. We mentioned earlier on about the disease spectrum as well as the time course of the disease. So from here, You can see that most of the patients would develop pulmonary disease, pulmonary manifestations around about second week of clinical illness. With unchecked and dysregulations of inflammatory response, patients can then enter into a stage 3, which is the hyperinflammatory phase. And again, without treatment and with unchecked hyperinflammatory response, the patients can then enter into critical phase with multi-organ failure, or in fact may succumb to the infections. Now, using that information, from what we can understand, in today's approach in therapeutics, we have evidence from recovery studies showing the clinical efficacy of using steroids in patients with severe disease, patients that require oxygen supply, patients that require mechanical ventilations. You can see a reductions in the mortality with the use of steroids. There are still more work need to be done in terms of using antiviral for the treatment of COVID-19. And one of the drugs that is currently being looked at and being used in a trial is the utilizations of the remdesivir as a treatment therapeutic agent. Now, more information are in fact needed to have better understanding, but the point here that I want to raise is that it is important to look into patients' manifestations and time course, looking for a sweet spot where we can intervene effectively to prevent patients from going into critical phase. Be it we use antiviral treatment or we use steroid, what we want is to be able to control hyperinflammatory response and therefore give the patients a better chance of recovery. With that, I would like to conclude my presentations on today's topic on inflammatory response due to COVID-19. Thank you for your attention, and I wish you a very fruitful convention. Thank you.
Thank you very much, Professor Leo, for that excellent presentation on the pathogenesis of COVID-19. It's just unfortunate that Professor Leo Yee-Sin could not join us personally during this plenary session. So we will just forego with the question and answer. Certificate of appreciation to Professor Leo Yee-Sin for her invaluable service to PSMID on the topic inflammatory response due to COVID-19, signed by Dr. Burba, Dr. Biglor Manginsay, and our President, Dr. Marisa Aliandria. Thank you very much for your presence, everybody. This ends the session 2 of the PSMID Annual Convention.
Good evening. Good evening, everyone, and good evening to my colleagues in the PSMID during this very important occasion, the 50th anniversary of the PSMID. It is truly my honor and privilege to present to you our next plenary speaker, who is homegrown but truly world-class. She is the coordinator of the Unit on Economic Evaluation and Analysis under the Department of Health, Systems Governance and Financing at the World Health Organization in Geneva. For the past 20 years, she has been primarily responsible for leading the work on defining the cost-effectiveness of health interventions, the WHO Choice program, and the costs of scaling up and reaching health goals and targets, as well as working on health expenditures and the monitoring of financial protection. Together with co-authors, she recently published the Global Prize on the COVID-19 response in Lancet Global Health. She has also been recently contributing to the costing of the Health System Connector with the ACTA, or Access to COVID-19 Tools Accelerator, and also in reviewing COVID-19 costing tools. On a personal note, I know her as my colleague in the section of infectious disease at the UPPGH before she joined the WHO. So it gives me great pleasure to present to you a world expert, a true professional, an infectious disease specialist par excellence, and a friend. I'd like to present Dr. Tessa Tan-Torres, Edejer, to talk on the economics of pandemics.
Thank you, Jimmy. I want to have a voice check. Is this good?
Yes.
Okay.
Very clear.
I'd just like to start saying good evening to all our friends and particularly to Jimmy as well. And I'm very honored to be able to speak on this topic, which is very close to my heart, which is on economics and something on which we've been working on for some time. And this is on COVID-19. Could I have the first slide, please? Okay, so next slide. What is WOTI? It's this is word of the year, and Collins Dictionary in 2020 nominated the word lockdown as the word of the year because in the year 2020, there were more than 500,000 searches for this word compared to about 4,000 in 2019. Lockdown or containment measures or mobility restrictions have been a basic part of our life this 2020. Next slide, please. In the Philippines, you see all sorts of manifestations of these mobility restrictions. And in fact, the Philippines has the reputation of having the world's longest and strictest coronavirus lockdown. Whether this is true or not, it is legendary. Next slide. Why is it so difficult to make decisions on social and movement measures or containment measures or lockdown measures? The first is because it is a truly complex decision. It impacts on something so basic to us, our lives and our livelihoods. It also has a differential impact across population subgroups. It impacts on the elderly, on those with comorbidities, and those from the lower socioeconomic groups. The other interesting thing is it also has a massive impact now, but we now know for sure that this impact goes into the future, not just the health impact, but also the economic impact. The decision is even harder because of uncertainty. This is a new virus which was just made known to us this year. The knowledge is really piling up and there is an infodemic. And we have to cope up with all the new literature coming in, plus all the fake news as well. Also, what has happened before in the past 6-7 months does not predict what will happen in the future. For example, the virus interacts with us, and we interact with the virus in terms of our mobility. Whereas we might have been very scared before, right now, there is mention of pandemic fatigue. And this comes because it's been so long with us that we grow used to it. We start disregarding risks. And for many of us who are unable to sustain the livelihood, sometimes we have to go out because we have stopped receiving any social support that had come our way before. There is also the need to make decisions very urgently. We are in a pandemic, and every delay in terms of calibrating our containment measures will result in massive changes because we are talking about exponential curves. And finally, there is a need, because this situation is constantly changing, there is a need for frequent monitoring, recalibration, consultations, and communication. So it is really a very, very complex area for decision making. Next slide. Why is it additionally very complex? It is because we have so many policy options. We have so many control knobs in terms of what and how and when to calibrate. If you look at this slide, there are so many measures that you can take, from stay-at-home restrictions, closure of schools, closure of workplace, canceling public events, restrictions on gathering size, closing public transport, restrictions on domestic movements. But we shouldn't stop there, because you can calibrate this finer by looking at stay-at-home restrictions by age group. For example, in the Philippines, you have restricted older people from going out, closure of schools, whether by university level or even the grade school level, closure of workplaces for those providing essential services, you usually keep it open, canceling public events of a certain size, etc. You can see that there are finer control knobs with which we can work for this movement measures. Next slide. So there is really no one correct calibration policy. There are so many fine control knobs that you can use. The most important thing is to get a consensus on the main objective. And in general, this would be, first, we will implement measures proactively. And these measures are intended to result in the least possible harm in terms of our lives and livelihoods, while we protect the vulnerable, and given the current knowledge and context. To do all of this, to consider all these different factors, we need a decision framework. And we need it now and in the near future, even with news of the forthcoming vaccines and therapeutics. this vaccine will still be with us for some time. We have a new normal. Next slide, please. So the World Health Organization, the World Bank, and OECD put together a publication entitled Sustaining Lives and Livelihoods, a decision framework for calibrating social and movement measures during the COVID-19 pandemic. Next slide, please. In the report, we cover the global impact on health and the global impact on economy. For this particular presentation, I have tried to tailor it using Philippine data that is publicly available. And then we go into the decision framework. So next slide. The next slide is very familiar to you. This comes from the DOH COVID-19 tracker. And it shows you that currently, or as of yesterday, I believe there are 430,000 confirmed cases of COVID-19, of whom 8,373 have died. And with all the caveats about interpreting the results, you see a curve which has reached its peak and hopefully is going down. Next slide, please. What is the health system capacity in terms of dealing with COVID-19? This comes from the Q3 NEDA report as of November 6. In February, there was almost zero lab capacity, and now there are 160 labs capable of doing 111,000 tests per day. The peak was demonstrated at about 46,000 tests last September. Early on, there was a handful of DOH personnel who were doing contact tracing. As of now, there are over 253,000 trained contact tracers deployed across the country. And in the NEDA report, they say that there are 21 or almost 22,000 hospital beds all over the country which are dedicated to COVID-19. And as of November 6, there was 39% occupancy. Next slide, please. What has been the economic impact in the Philippines? This slide shows you the real GDP growth rate from 2016, you can see it on the horizontal axis, to 2020 up to Q1 to 2. You know all of these figures, or you see it in the newspapers. Our growth rates have been ranging from 6% to 7+%. But as you can see, from Q1, you have this massive drop to -16.5%. Q3 has improved a little at -11.5%. But you can see the massive decrease in our growth rate because of COVID-19 and as a consequence, as the slide says, of the expanded community quarantine. This is a percent. What does this actually mean? Next slide, please. I hope you're not seeing this for the first time, but when I saw it, I had to step back and say, wow. So this was estimated by our economists in the Philippines, and they show you the expected or estimated losses per day during the quarantine. And you can see if it's really expanded, then you have the highest losses per day, reaching up to 14.6 billion early on in the epidemic. And then you see the general community quarantine in the past 26 days from August 19 to 26 days after that at about 8.6 billion per day. Those are very, very big numbers for our country, and they are very big losses. What does this actually mean for the household level? Let's bring it down really to the household. Next slide, please. A survey had been run in the Philippines and other Asian countries. And this shows you the percent of the households with at least one person who lost his job or her job or experienced a reduced workload. What is the highest bar there? It is the Philippines. And in this survey, it showed that about 73% of the household surveys are claiming that they have lost a job or have had a reduced workload. The next, the other graph shows you how many households have claimed financial difficulty during this time. And again, you see the biggest part for the Philippines with over, is it 80%, I believe, claiming financial difficulty. So it has had a huge impact on many households, both COVID-19 and the associated quarantines. Next slide, please. How have they coped with that? These are the strategies that these households have mentioned. They have reduced consumption or expenditures. They have drawn from their cash and savings. They have borrowed from friends. They have borrowed from microfinance institutions. Baka kasama dito yung mga 5-6 kung meron pa dyan. They have deferred payments and debts, reimbursements. They have sold stocks at lower prices. And then they do online businesses like selling homemade foods or items. And a few have applied for social and government aid. But you can see that many of these coping strategies actually impact on the future well-being of the family because it eats into their savings and into their investment for the future. Next slide, please. I was unable to within the time available, show what is the differential impact of COVID-19 on subpopulations in the Philippines. But these global findings apply as well in the Philippines, I would think. There has been more impact on the sectors which are less amenable to physical distancing, and this includes manufacturing, construction, tourism, and retail. Those who are temporary, seasonal, or self-employed and informal workers also suffer more because they have lower wages and lower insurance coverage. There is a demographic and gender bias with younger workers and women suffering more. Geographically, it is the rural poor and the new urban poor who are disadvantaged by this COVID-19. And finally, there is a backlash on low and middle income countries. And everybody knows that there has been a massive decrease in remittances to the Philippines with about a large number of overseas contract workers coming back to the country because they have lost their jobs abroad. Over. Next slide, please. So where are we now? This is in the Q3 NEDA report, shows you what was the state of the quarantine at the time that of the numbers that I showed you. The one I want to mention is in August 2020, the National Capital Region reverted to modified expanded community quarantine status for 2 weeks. And I believe this has been a result of advocacy by the medical community in the Philippines. Right now, you are in GCQ. So let's see what this means at present. Next slide, please. There is a lot of data available on mobility. This is the one which I downloaded from the on the National Capital Region, showing you the impact in the recent days on mobility. And it tells you that compared to a baseline in January, February of this year, there is still a 46% reduction in areas with retail and recreation, parks, and workplaces. Transit stations have a 62% reduction compared to the baseline, and grocery and pharmacies have less than 14% reduction compared to the baseline because they are considered essential services. What is the next slide, please? What is the percentage compliance with public health measures in the Philippines? Again, this is data from about 3,000 people being surveyed, and it is almost up to date as of November 23. It shows you that the percent of people who say they are avoiding crowded places is about 80%. Almost the same percentage who say that they are wearing a face mask, and quite high as well for those who are practicing hand hygiene. So at 80%, that's quite a good compliance, but there is still an area for improvement on this. So overall, with the current quarantine in the Philippines, there appears to be quite a reduction in mobility and good enough compliance with public health measures. But in both cases, there can still be improvement. So how do we use this data to inform, to calibrate our ECQs or GCQs or our containment measures? Next slide, please. The health impact is a reflection of both the health system response capacity as well as the effectiveness of the social and movement measures in place. So we can classify the indicators that we have gone through into three groups. The first group, the most recent ones which I showed, are the behavioral response indicators on public health and social measures. So you can see the mobility measures, you can see the public health measures in terms of mask wearing and distancing. Then you have the epidemiology indicators and the health system response indicators, and we will go into this in more detail in the next slide. Next slide, please. So this is the first step of the decision framework. The table that you see there, or the figure that you see there, comes from the most recent update of WHO in November 4 on public health and social measures. And the first step is to assess the situational level. And here you can look at the rows. You have the transmission levels of no cases all the way down to community transmission level 4. On the columns, you see the health system response capacity, which range from adequate to limited. And then in the cells itself, you see numbers ranging from 0 to 4. And I will say it here right now so that you can relate the future slides into what you have in the Philippines. Situation levels 0 to 4 would probably correspond to your, number 4 would respond to the expanded community quarantine. And then you also have your modified, and then you have your general community quarantine. So in this particular example from WHO, the number of levels of responses are ranging from 0 to 4. And in the Philippines, I believe there are about 3 from what I see in the newspapers. So what is the first step? The first step is to agree on the indicators and the thresholds for the transmission level and the response capacity. That means we assess the current epidemiologic data and we assess the health system response capacity. And we have done that in the previous slides. And then we basically classify where we are. At the same time, we also look at our adherence to public health and social measures, and we have also seen that in the previous slides. The whole point here is the recommendation is to increase health system capacity where possible, and we need to optimize adherence with public health measures so as to minimize the amount of disruption to our normal mobility. So how do you classify into the transmission level? Next slide, please. This is a big table. It shows you the different indicators that could be used to classify the situation in the country on the specific level of community transmission. So you can look at hospitalization rate, mortality, case incidence, and testing. Testing, for example, test positivity as a proportion of all tests done. You have the description and the rationale and the major limitations when interpreting this. So they suggest, so WHO suggests that you don't just use one indicator, but you use several indicators to then compare yourselves with respect to the thresholds as suggested here. So if you can see in test positivity at the bottom row, community transmission 1 is a less than 2% positivity rate. 5% has been mentioned as one of the thresholds, and you can see it between community transmission 2 and community transmission 3. And if you have more than a 20% positivity rate, then you are actually with a real widespread community transmission. So what is the current positivity rate of the Philippines? From publicly available data, it sort of is hovering about 5%. So just using this single indicator, which you shouldn't do, but which is the only number I have at the moment, it would be somewhere between community transmission 2 and 3. So that takes care of where we are in terms of the transmission level. Let's go to response capacity. Next slide, please. The response capacity can be evaluated using the following indicators: clinical care capacity, clinical care performance, public health response capacity, and public health response performance. So you have the indicator there. Let's start with clinical care capacity, proportion of occupied hospital beds. If you remember from the NEDA report, it was about 39%. So if you follow this classification, the capacity to respond, just again using one indicator, which is not what is recommended, this would be considered as adequate response capacity. So now you have, if you want, using just this single indicators, you would say there is adequate response capacity and community transmission 2 or 3, which gives you an assessment level of 2. And this apparently corresponds to your general GCQ. Let us see what it means in terms of the WHO suggested recommendations. Next slide, please. So once you have the level, you would then look at the suggested actions. And here you can find it. Situation level 4 would be almost locked down. You can see that would be basically if you have widespread transmission and you have limited health system response capacity. And these are the actions that will be that are suggested to be taken. Situation level 3, you have another set of actions. So this I'm trying to relate it to the experience in the Philippines. This would be similar to the set of actions for GCQ, MECQ, and ECQ, although they don't actually you have to see what corresponds with each other. Next slide, please. So this is now where we have added the economic dimensions to what WHO has recommended. WHO acknowledges that it is not only the health parameters that are important to take into consideration, but also the impact on the overall well-being of the population. So if you look at the previous examples of level 4 and level 3, and in the second column, you have the social and movement measures, which are mentioned here. We are then suggesting that you look at and evaluate the non-health dimensions in terms of the barriers to implementation, the cost of implementation, the cultural and social barriers, the economic cost, which we have discussed, impact on equity, and you can add other criteria which are important to the country. You would then look at each of these measures and evaluate it, and you can do it in an ordinal scale or in something like this, which is qualitative. You can weight the criteria. The more important thing to say is, in this particular case, the low and medium mean, probably you can use it, but once you see that there are red areas here, which means there are problems in terms of barriers or impact on equity, you need to think about mitigation measures, because that means in order for this measure to be effective, it means you have to be able to respond to what is the problem associated with that particular measure, and you have to do mitigation measures. So next slide, please. How do you put together a big graph like that with a lot of social values and judgments? You have to establish step 4, a dialogue and a decision-making process. This is the one in the Philippines officially stated as the Interagency Task Force for the Management of Emerging Infectious Diseases. And we have to distinguish, these are all government bodies, and we have to distinguish between a decision-making role, which is this, and the advisory role. My understanding is there is a technical advisory group, which is apparently led by one of our colleagues, Dr. Salvana. But it is also very important that a technical advisory group is not just advising on technical matters, but actually an advisory group also needs to look at the economic impact on the household, the social impact as well, and therefore the inclusion of stakeholders or those being impacted is also important and should be part of an advisory group, not necessarily a technical advisory group, but a bigger advisory group, and where we would recommend transparency, inclusiveness, and leaving no one behind. Next slide, please. And the final step is to set up a monitoring process with feedback mechanisms. You need to cycle through steps 1 to 4, and WHO suggests every 2 weeks reassessment. Please use the tools to sharpen communication, to build trust between the decision makers and the population, and build these elements into a systematic approach. Next slide, please. So as key messages, I will just read through this. There is an inescapable tension when making decisions around social and movement measures, around the need to balance multiple consequences on lives and livelihoods. A whole of government approach is needed. Monitoring indicators and modeling what-if scenarios can inform decision-making and should be really improved wherever it can be improved. This is a technocratic solution, this decision framework. It can assist with providing guidance for decision-making, but is not the entire process. The most important thing actually is the procedure associated with the decision-making, that it is inclusive of those vulnerable groups, of those affected, the teachers, the elderly, etc. it is transparent. Using indicators, it can trigger the actions, and therefore people know what to expect. It is multidisciplinary, and we embrace the complexity head on and do not hide behind formulaic answers. Decision making should be part of a well-established process where important considerations and many types of evidence are taken into context. We should strive to be systematic and non-arbitrary in decision making and being held in suspense in terms of whether it is this type of quarantine or this level of intensity of this quarantine. Having something which is transparent in terms of what triggers specific actions can build trust, and then can also improve predictability so that people can plan. We acknowledge that there are many competing viewpoints in a society, but having a clearly defined process and means of communications and channels for eliciting constructive feedback can help the decision-making process. It establishes legitimacy in this time of uncertainty, and it also increases the potential for effectiveness of whatever mobility measures are, because we encourage co-responsibility if those who are affected are part of the advisory group. And finally, the different contexts in each country, and even particularly now in the subnational areas, all of this need to be coordinated and well communicated. And the final slide, please. Thank you very much.
Thank you very much, Dr. Tessa. That was truly a wonderful lecture, very comprehensive and informative. I will now go to the open forum for the question and answer. A number of people have already sent their questions, and I will read them out. I hope you bear with me as I will screen them as I read them, the questions. So, are you ready, Dr. Tessa? Okay. Yeah. The first question is this. How do you feel about shorter and more reactive lockdowns as opposed to the very long one that we had, well, I suppose in the Philippines, and the need for us to beg for a timeout? I think this is the case you already mentioned a while ago, that the medical professionals and the healthcare workers actually asked for a timeout because of the increasing demand on their services and the pending, I shouldn't say collapse, but shortfall of the healthcare sector.
It's a little bit hard for me to react because I'm not on the ground. But I think what we are saying here is this decision framework, if it was in place, could have avoided perhaps the need for the medical community to actually demand in a very loud voice for those 2 weeks of going back to a more strict quarantine. What I'm basically saying is having a decision framework which has been agreed upon by all stakeholders probably improves its effectiveness because it is transparent and doesn't seem to be arbitrary. So whether short and frequent lockdowns are better than what you currently have in the Philippines, that's a bit hard to respond to. I think the question is, what are the outcomes that you should be looking at when you answer that question? Is it just the health outcomes, or is it also the economic outcomes? And how do you look at both at the same time? I cannot say anything. I think the whole point of what we are saying in the decision framework is those who are needed to decide are those who are implementing the response, as well as those who are being affected. They alone can say what is better. Is it their health? How has it impacted on their livelihood? I'm sorry to give a very big motherhood statement, but this is what we are trying to say, that really, because of the uncertainty associated with this, but because of such a huge impact it is having on lives and livelihood, there really is a need for transparency and for a decision framework for which the criteria, the indicators, the thresholds have all been discussed by those who are in the government, as well as those being affected, as well as the private sector, the business. Everybody has to agree so that you have co-responsibility and you know what you are accepting, given all the uncertainty associated with it. I think the other thing as well is when you are implementing lockdowns, particularly intensive lockdowns, then it is perhaps incumbent on the government to try to really maximize its fiscal capacity to provide social mitigation measures, so that, you know, we had all of these figures about percent of people, of households losing jobs and having financial difficulty. I think at this point, this is something that we really need to listen to as well. Over.
Yeah, thank you very much for that answer. I think the country response was actually moving from the response mode to the mitigation mode and the recovery mode. So I think during the response mode, as was already emphasized repeatedly by the leadership of the country, that their prime concern and emphasis is the health and well-being of people more than any other consideration. So in effect, that was also some transparency, but I understand the complexity of the issue, and the decision framework puts order and also transparency, because people would know what parameters are being considered, what problems are being given emphasis, and what consequences are being considered in coming up with a decision. Thank you. I have that question, by the way, came from Dr. Buensalido. And now this question is coming from Dr. Nina Castillo Carandang. So the decision framework which you shared does not seem to factor in community engagement and risk communication. Is this a correct interpretation of the framework? And if yes, do you think that community engagement and risk communication should be included in the decision framework?
It is part of the framework. It's actually the framework itself, people misinterpret it as the very big table. Actually, what we say, the decision framework includes the procedural considerations of having an inclusive way of coming to decision and making sure that one leaves no one behind. It's a bit difficult to talk about community engagement, but particularly where there are approaches to having subnational decisions on containment measures, then definitely you can get closer to the community there, and you can have more local decision making. That would actually be encouraged, that there is more treatment, if possible, to actually collect these indicators at a subnational level, so that you have a better and a finer basis for calibrating your containment measures. Risk communication is definitely part of the decision framework. Is not just there where people automatically do this in terms of it's here and then it's here and this is where we should go. It's not like that. It should be communicated in terms of the decisions, in terms of how the population can cope with this containment measures. So yes, it is a very intrinsic part. I'm sorry if it didn't come out in the presentation, but it takes quite some time to get through the actual table itself. But thank you, Nina, for reminding us about community engagement and risk communication. It is key if we want this to be effective. Over.
Yeah. Again, thank you very much for your response, Dr. Tessa. I'd like to just sort of summarize some of the questions here because some of them are, well, not really directly related to your topic, but since you are from WHO, I think that's the reason why these questions are being asked. But I would already give them to you, but I'm just telling you in advance that this may not be directly related to your topic. For example, there's a question here about vaccines. Maybe the question here is, what role do you think will vaccines have as far as this whole decision framework is concerned? And if I may give a connecting question is, what about the role of local government units? As if they're talking here of decentralized governance. In the Philippines, you know, it's a highly devolved setup, particularly in the healthcare sector. And is it also being considered in this decision framework?
Okay, so if with the vaccines, we're basically saying that there's still a need for this decision framework. There will be some supply constraints initially, and there are the logistical constraints in getting it out to the to many countries. I think there might be one of my colleagues in WHO, our chief scientist, Sumya, is going to be one of your later on, and she will be discussing the vaccine area more substantively. It is just to say that because it really, I think people have heard the magic numbers of 60% immunity would probably be where you can start to see the beneficial impact of herd immunity coming in, and it's a minimum. Before we get to that point, it will probably take some time, despite all the efforts of the Philippine government, even in many other countries, even in Europe and the US. The challenges are there in terms of immunization. But I think the faster we get to vaccination, the less we can depend on these lockdown measures. But for the moment, it will still be with us. The role of local government units, I think, as I say, if it is possible to collect the data at that lower level, I would encourage decision frameworks and decision-making bodies to actually be activated at the lower levels where you have community transmission of levels 3 and 4. And really, even when I'm saying this, the most important thing as well, of course, is even if we have autonomous LGUs, they should be coordinated. I seem to remember funny stories about stopping between borders and not being able to enter because there were different rules across LGU. So while we encourage more localized decision-making and not national lockdowns anymore, I think the most important thing to remember about this is coordination of these measures. Over.
Yeah, Dr. Tessa, again, that was quite very interesting question and answer. But in the interest of time, I'm sorry, but we have to cut it short. I'm honest to say that there are a lot of questions here which I will not be able to forward to you now, but I can send it to you later. Maybe we can, although most of the questions here are anonymous, so I'd like to apologize for not being able to ask all of the questions because in as much as we would like to do that, we are running out of time. We still have another speaker. So I'd like to take this opportunity to thank our distinguished speaker. Truly very interesting lecture. We learned a lot and it gave us very good insights, both at the national level and at the local level, meaning at the Philippine level, global level and Philippine level. So I'd like to thank Dr. Tessa Tan-Torres Edejer, and we'd like to present the Certificate of Appreciation to Dr. Tessa Tan-Torres Edejer for sharing her invaluable expertise as a resource speaker on the topic of the economics of pandemics. Given this 42nd PSMID Annual Convention, December 1, 2020, signed Dr. Regina Berba, Scientific Committee Chair, Dr. Viglor Maginsay, Vice President and overall Chair, and our President, Dr. Marisa Alejandria. So let's give a big virtual applause. Thank you very much, Dr. Tessa.
Thank you.
Good evening and welcome to this last plenary session of this day one of the PSMID Annual Convention. It is with privilege to introduce our next esteemed speaker to talk about how to stay evidence-based in COVID-19. It is clear that how science and evidence-based informed policy had shaped our response to this pandemic. And to discuss further with this particular topic, I would like to formally introduce our next speaker. Our next speaker is Dr. Mary Ann Lansang, one of our mentors and always the pillar in the field of research and particularly evidence-based medicine. She has had several of these peer-reviewed papers, but I would like to specifically mention her latest achievement in terms of international collaboration. She's the chief of party USAID Philippines Collaborating, Learning, and Adapting for Improved Health project from 2018 to 2022. She is also a member of the World Health Organization Expert Advisory Panel on Health Science and Technology Policy from 2012 up to 2021, a member of the Working Group of TDR Global Community, WHO Special Program for Research and Training in Tropical Diseases 2017 up to 2021, and currently also a member of the Scientific Advisory Group, Southeast Asia Community Observatory, University of Monash, Malaysia, from 2016 to 2021. Ladies and gentlemen, colleagues, it is with honor to present our next speaker, my mentor, our mentor, Dr. Mary Ann Lansang.
Good evening, everyone, and thank you for that kind introduction. I was invited to talk on how to stay evidence-based in COVID-19 decision-making. I have nothing to declare for this talk. And these are the objectives that Dr. Nina Berba asked me to focus on for this talk, to describe the current surge of publications on COVID-19 and the quality of information being shared, to provide guidance on how to efficiently manage the volume of new knowledge and published data, and finally, to share practical tips to busy clinicians like yourselves on how to critically appraise and find the relevant evidence for your practice. What is this talk not about? I'm going to emphasize that this is not about COVID-19 epidemiology, diagnosis, treatment, and prevention. PSMID has prepared for you an excellent program that will discuss various aspects of COVID-19 management, so I'll not go into that. Neither will I talk about COVID-19 clinical practice guidelines, nor public health guidelines, nor will I review with you the top-rated peer-reviewed journals that I assume you are already reading regularly. This talk, in this 30 to 40-minute talk, it's really about how to navigate the COVID-19 information superhighways, loops, byways, and detours. So if you will, you can call this a travelogue, but not a comprehensive atlas of the evidence out there. Let's start by how this story began with Dr. Li, an ophthalmologist in China, who observed 7 cases of respiratory infection that were similar to SARS, the pandemic in 2003. And so in December, what he did was he actually alerted his colleagues about the viral infection that he was observing and warned them that they should be wearing PPE. This was on WeChat, the popular social media channel in China. This was done on December 30. And 4 days after Dr. Li posted that, the Public Security Bureau summoned him and asked him to write a note or a letter that what he had posted was something that was not really true. And there were 8 other doctors who were also investigated on this. But eventually, the Public Security Bureau apologized when they noted that there were indeed increasing cases of SARS-like infection in China. In fact, in January, Dr. Li himself, early January, Dr. Li himself started to cough, and the next day he started to have fever, and 2 days later, he was hospitalized. He got his infection from the Wuhan Central Hospital where he was working. And it was only on January 30th that he was diagnosed to what is now known as COVID-19 disease. Sadly, on February 7, Dr. Li passed away from COVID-19. Now, since then, there has been a knowledge explosion on COVID-19. If we will just look at the US National Library of Medicine, PubMed, last week there were already 69,724 publications on COVID alone. And you can see the meteoric rise in publications from around February to the present time. And these are only journal publications. These do not even include preprints, which we know have increased over time. I'd like to pause and share this photo with you, some nostalgic memories. This was taken in mid-February. My classmates and I went to Batanes, class 78. So we are all over 60 years old. We were jumping for joy in the fresh air and verdant pastures of Batanes. And that was the last time we were really free to move around and enjoy ourselves. That is what COVID has done to us these days. Now, if we look at the clinicaltrials.gov, which is also maintained by the US National Library of Medicine, you can see that there are more than 4,000 clinical trials already registered in this US clinical trials registry. And we can foresee that, at least for the foreseeable future, these studies and publications from these studies will continue to rise. Now, this one is from medRxiv, and Dr. Wilson from Medscape called 2020 the year of the preprint, because if you will see, from the time medRxiv was established in June 2019, and from the time COVID interest really rose, there has been an increase in the manuscripts submitted to medRxiv. And from June 2019, their first year alone, there were over 11,000 manuscripts submitted, and their acceptance rate is close to 89%. So very few are rejected. And out of the manuscripts submitted between February to June, almost 75% of those manuscripts are about COVID-19. And from all these preprints, only 18 have been retracted from medRxiv, but 13 of them, of those retractions were about COVID-19. So really what BMJ and Yale, who collaborated on medRxiv, did was to respond to the really slow peer review process for journal publications. But one important caveat to medRxiv, which is put on their homepage, is preprints are preliminary reports of work that have not been certified by peer review. They should not be relied on to guide clinical practice or health-related behavior and should not be reported in news media as established information. So please take this to heart when you download PDF files from medRxiv. When you download those PDF files, you don't always see this watermark about this caution, okay? So just remember, they are not peer-reviewed, and you have to really critically appraise what you download from medRxiv. Look at this example of hydroxychloroquine, the roller coaster ride of hydroxychloroquine. In early February, there was a laboratory study, an in vitro study, that the aminoquinolines like hydrochloroquine can actually inhibit SARS-CoV-2 in the lab through cell culture models. And shortly after that, there were other studies until Professor Goutre in France shared this preprint on hydroxychloroquine and azithromycin. And that really shook up the world. In fact, POTUS, when we say POTUS, that's the President of the United States, tweeted that hydroxychloroquine and azithromycin were game changers. And shortly after, the US FDA issued an emergency use authorization for hydroxychloroquine in the management of COVID-19. And in April and May, there were many studies about hydroxychloroquine. Foremost among this is the pre-exposure prophylaxis study on hydroxychloroquine among healthcare workers, which started on April 6th. But again, while this was going on, there were many other pronouncements about hydroxychloroquine. One study showing no effect, while the NIH guidelines had no recommendation for or against hydroxychloroquine. And then another study talked about the cardiotoxic effects of hydroxychloroquine, although this was later retracted. And for those of you who participated in the WHO Solidarity trial, you will recall that in late May, WHO halted enrollment for hydroxychloroquine in the Solidarity trial because the increasing evidence was that it was not really effective for COVID-19. Finally, in mid-June, US FDA revoked the emergency use authorization of hydroxychloroquine, while the US NIH recommended the use of hydroxychloroquine except in the context of a clinical trial. So we have a perfect storm of true information versus false information. And this is because of the interactions of social media, media hype, populism, and politics coming into play. Of course, scientific discourse was very much evident, but also quasi-scientific discourse by various so-called experts who were really, who did not really know what they were talking about. And finally, major influencers like the President of the United States, who tweeted, and you can see that he has a lot of followers. In fact, he has millions of followers. And he tweeted that hydroxychloroquine and azithromycin constitute one of the biggest game changers in the history of medicine. Let's listen to him here.
There's a possibility. And I say it, what do you have to lose? I'll say it again, what do you have to lose? Take it. I really think they should take it, but it's their choice, and it's their doctor's choice or the doctors in the hospital. But hydroxychloroquine, try it.
So with all that confusion, sometimes we are tempted to just IgMG. And for those of you who still don't know what IgMG means, it's down here in the Urban Dictionary. And that's what we more or less start to do when we don't know answers to our clinical questions. But there is a better way to do that, to be evidence-based in our clinical practice. And here I'd like to show this hierarchy of evidence. And I drew it as a golden cake in honor of the 50th anniversary of PSMID. And you will see that this 5-layered cake starts from level 1 down to level 5 evidence. Within each level, there are various sub-levels. So for example, for level 1, the best evidence, I would say, we're talking here about systematic reviews of randomized controlled trials. But please take note that the highest level of evidence on systematic reviews should be those with homogeneity, not apples and oranges, but in fact, studies that are actually measuring the same thing. The next level of level 1 evidence would be individual RCTs with narrow confidence intervals. And finally, all or none RCTs. When we say all or none RCTs, those would be randomized controlled trials where you observe a lot of deaths, but when you introduce your intervention, somehow there are less deaths or even no deaths. So, for example, with rabies, if you have 100% mortality and then you have an intervention that will reduce mortality of some or many of the people, that would still be level 1 evidence. In level 2, you have still systematic reviews, but this time, this would be systematic reviews of level 2 evidence, in other words, cohort studies. Again, these must be homogeneous studies. Then, of course, we have individual cohort studies and outcomes research and ecological studies, which are really lower level because of the risk of bias and confounding in these ecological studies. The third level would be systematic reviews again, but this time of case control studies. And again, the emphasis on homogeneous studies within the systematic reviews. Below that would be individual case control studies. Level 4 would be case series, just like the case series presented early during the days of hydroxychloroquine hype. And finally, level 5 expert opinion, especially those experts who really do not explicitly critically appraise the evidence. And of course, in vitro studies, lab studies, and proof of principle studies. And for diagnosis, we have the same 5-layered golden cake with systematic reviews of level 1 diagnostic tests being first. And cohort studies are acceptable as level 1 as long as there's a good reference studies. And then what we call absolute spins and snouts. In other words, when the test is positive, you can really rule in the disease because the test has a very high specificity. Or when negative, you can rule out the disease because the test has a very high sensitivity. In level 2, you have, again, systematic reviews, but those are of level 2 quality diagnostic studies. Then we have non-consecutive studies of non-diagnostic tests, case control studies with very poor reference standards, and finally, level 5, the same expert opinions without explicit critical appraisal. So these will guide you when you start to read the literature on which is the best evidence and what you can apply to your practice. Now, the grade system is one of the most popular ways of assessing the evidence out there. It's a transparent system for rating the quality of evidence, especially in systematic reviews and guidelines, and for grading the strength of recommendations. It has been widely adopted. In fact, over 100 organizations are using the grade system. There could be a level of subjectivity in evaluating or assessing studies, but there are really ground rules for the evaluators and developing consensus. So it's still the best system out there to really determine if you have good evidence on which to base your practice. Let's do a quick overview of the process of grading the evidence. First, you start with a relevant clinical question, and that relevant clinical question has these 4 elements. You must have in your PICO clinical question, the people or population being studied, the interventions being studied, and what are they being compared against, and what are the outcomes. When you have determined that, you can then determine, do a systematic literature search and sort the literature based on the criteria that you outlined with your PICO questions, and then grade the evidence. Through systematic reviews, you can actually pull the estimates of the outcomes and then determine the quality of the evidence. It can be very low, moderate, or high. When we talk about high quality evidence, that means that you are fairly confident that even with succeeding evidence, it will not overturn the evidence that you have on hand. Whereas if you have low or very low quality of evidence, this is really saying that if there's new evidence available, it might very well overturn the current evidence that we have. When you grade the evidence, you can actually grade down or grade up the level of grade 1, 2, 3, 4 evidence, depending on whether there's risk of bias, imprecision, inconsistency, very indirect evidence, or publication bias. In this case, even if it's level 1 evidence like randomized controlled trials, if you have these elements, you can grade down the level of evidence. On the other hand, you can grade up the level of evidence if there's a large magnitude of effect. For example, you have a cohort study, but the magnitude of the effect is very large. You can grade up the evidence. Or if there's a clear dose response gradient, or you have accounted for residual confounding in the study, then you can grade up. By doing that, you're able to really synthesize the evidence out there and pull the estimates to give an idea to the users and readers, whether, for example, in this figure, whether convalescent plasma is effective in COVID-19. And this forest plot, which you see this is a familiar diagram that you see in Cochrane reviews, shows you that if this is 1, in other words, 1 being the odds ratio for no effect, for convalescent plasma, there's a tendency towards favoring convalescent plasma for COVID-19, but because it reaches the 1 odds ratio mark, it's really not statistically significant. If it's over 1, this favors no effect of convalescent plasma. So there is a tendency towards an effect, but it's not statistically significant. And so when the evidence increases out there, this might either be pulled downwards to less than 1, or it might be pulled out there. So you're really not sure about, I would say that this is not still strong evidence for the effect of convalescent plasma for COVID-19. So the grade system is an optimal and systematic method to assess best evidence. However, it can also be very cumbersome. In fact, the Cochrane review, Cochrane estimates that a systematic review can take an average of 67 months to complete. And that's our experience when Dr. Alejandria and I and other colleagues actually did a systematic review of IVIG in septic shock. It took us a year to complete the review, and of course, several years to update the reviews whenever there's new information about IVIG. In this day and age of COVID-19 infodemic, however, we need a system that's more rapid than that kind of old system of systematic reviews. We need rapid guidelines because clinicians will want to know the latest evidence to guide of their patients. So we need rapid systematic reviews, but at the same time, we have to make sure that we do not cut corners when we develop rapid guidelines or rapid systematic reviews. And therefore, it's still important to stick to the principles and process of the grade system when doing these rapid reviews. So are there actually websites and resources that are trustworthy, of high quality, evidence-based, rapid, and accessible for clinicians and for decision makers? Yes, there are. And in my short talk, I'll give you a sample of what those trustworthy websites are, and I'll be putting a gold medal on these websites that I'll be navigating. First, of course, the most popular would be the Cochrane Library, and the features of these would be that the Cochrane Library has Cochrane rapid reviews, especially about COVID-19, which is our interest today. It has living systematic reviews. When we say living, they're constantly updated once there is new evidence. They also map the studies that are out there, and it's a living mapping. So when there are new studies, they are also incorporated into their database. The Cochrane reviews also do network meta-analysis, and this is when you compare various interventions simultaneously, still doing meta-analysis, but it's a more complicated type of meta-analysis because you're doing several interventions, you're evaluating several interventions together. I would say one of the big strengths of the Cochrane reviews would be that they have a plain language summary, even for lay people, and they have Cochrane clinical answers for clinicians who want a rapid answer to a clinical question. So check these out, because when you read the Cochrane reviews per se, they can even run up to 60 to 100 pages, and you may not have time to do that. So you may want to look at these resources like the Cochrane clinical answers or even the plain language summaries. An offshoot of the Cochrane Library is the COVID NMA website. And here, the COVID NMA initiative is a living mapping and a living systematic review, mainly of COVID-19 trials. And the ones who run this are also from Cochrane, but most of them are in the other side of the Atlantic, mostly in Europe. And they do this in cooperation with WHO, because WHO maintains the integrated clinical trials platform. So it's a registry, global registry of clinical trials. And so this COVID NMA initiative reviews these ongoing registry. And so they have a living mapping of all COVID-19 clinical trials based on the WHO integrated clinical trials platform, living synthesis of all available trials, living mapping of studies, just like the Cochrane Library, living evidence syntheses, and they actually do living monitoring of trial planning, conduct, reporting, and implementing interventions. A lot of work, and this is the process that they do. They screen regularly the controlled trial, clinical trials registry of WHO. They have a data visualization system for the trials that they are monitoring. There's a daily search of the literature. They do, of course, risk of bias assessments and evidence grading. They disseminate systematic reviews weekly. They monitor the data. And of course, they disseminate this to decision makers and to clinical practitioners and public health practitioners. Here's a sample of the living map that they have on their website. This is a static image, but if you go to their website, if you click on any of these, including if you can find the map of the Philippines, you'll find that, for example, last week, the Philippines was participating in 5 clinical trials, ongoing clinical trials, all in cooperation with other studies in the world. So you can see where there are a lot of clinical trials going on, and you can actually filter the map to see the topic that you are interested in. You can also see the meteoric rise of clinical trials over time. Here's another website, Epistemonikus. And I'd like to share this because it was endorsed by the father of evidence-based medicine, Dr. Gordon Guyatt. And the feature of this website is really, it caters to non-English speaking users. This is maintained mainly by systematic reviewers in Latin America. And you can see that they are also participants to the LOVE resource. When we talk about the LOVE resource, that really means living COVID evidence, living coronavirus disease evidence. And in their database, they have over 67,000 primary studies. They have over 2,500 systematic reviews and do broad synthesis as well. So it's also a very good resource for you to look at. And here's an interesting resource for those who develop clinical practice guidelines. It's called MAGIC. And what is MAGIC? MAGIC stands for Making Grade the Irresistible Choice. What a nice name. And it's actually a platform for authoring and publishing clinical practice guidelines. It will, so for me, it gets high marks, a gold medal for this online authoring and publication platform for practice guidelines, evidence summaries, and decision aids. And this is how it looks. This is, it can help you with the database. It can help you develop decision aids and publish those. It can help you integrate these into electronic medical records, and it can help you also with preparing them in various platforms, including mobile phones. So here's the system that they have. There is support from the MAGIC app for these various processes in developing guidelines. And underneath this support, there's a technical infrastructure of a sophisticated software that helps you develop and author and publish the guidelines that you have. So I would encourage PSMID to register as an organization in this Norwegian nonprofit organization, MagicNet, so that you can avail of this MAGIC app. So I can't go through all the resources, but I'd like to cite this resource, the COVID-N, because at the end of the day, if I'm not giving you an exhaustive list, but this COVID End actually is a living hub of COVID-19 knowledge hubs. So it's a hub of hubs. And it's a resource for decision makers, for researchers, for clinical practitioners, and it's a searchable database. So this is how it looks when you go to their website. They have, of course, screening criteria. They will not just put any old website into this. It has to pass the criteria for good resource and good evidence. And you can look through it. It can be filtered to see what kind of COVID-19 evidence you really want to find. And finally, of course, I will not elaborate on this because I know that you look at these websites very regularly, the WHO website for its guidelines, the Infectious Disease Society of America for its guidelines. NICE in the UK also has developed very nice evidence-based practice guidelines, and the US CDC, although tainted in the past with some politics, it's still a good resource for guidance for COVID-19. Lastly, I'd like to, of course, cite our own, very own PSMID website because it has guidelines tailored to the context of the Philippines. We may have all these resources internationally, but the guideline developers within PSMID and other evidence-based practitioners who cooperate with PSMID and other societies, they develop these rapid guidelines and rapid evidence reviews, for example, together with the UP-NIH Institute of Clinical Epidemiology, taking into context the resources that we have in the Philippines. Another good source, of course, is the HTAC, Health Technology Assessment Council website of the Department of Health, because they do assessments, and one priority for them would be technology assessments for COVID-19. Before I leave, I'd like to leave you with some tips or takeaways. And because it's our golden anniversary, the tips I will share will be using the mnemonic GOLD. G stands for grade the evidence. When you look at the literature, please try to use the levels of evidence and the grade system in developing practice guidelines or in applying the evidence to your practice. O stands for only trusting trustworthy evidence sources, as I outlined today. L stands for living sources and lifelong learning, because what we know today could easily change tomorrow when more evidence from trials and other studies come. So it is important that you always do have the principle of lifelong learning. Otherwise, you may be using outdated evidence in applying management to your patients. And letter D stands for disseminate only good evidence. In other words, don't just pass on tweets, don't just pass on Facebook posts. Be responsible enough to read what is tweeted or what is posted, and make sure you critically appraise it before you actually disseminate it to your colleagues or to the population at large. So remember GOLD when you want to be evidence-based. Thank you, and congrats again to PSMID on its 50th anniversary.
Thank you, Dr. Lansang, for that very extensive and insightful topic on how to stay evidence-based in COVID-19. So I'll check on the Q&A. Oh, there's no Q&A. So I think I am now privileged to ask a question. Either you will give a comment or give some principles of EBM that we can take also on this next question or this question of mine. This is with regards to COVID vaccine, and I think there are now 4 candidate vaccines already in the interim, the phase 3 clinical trial, releasing their interim result and not yet peer reviewed. But a lot of countries are already ordering in advance these vaccines. Can you comment in terms of the principle of EBM, what is right and what is something not right at this point?
Thank you, Jean, for that question. So, unfortunately, because everybody's waiting for the vaccine, the press releases and the excitement of people has actually moved forward, and science is behind in terms of releasing the full evidence and releasing the data. So I think we should be cautious about this. We are all excited. I am excited about these 4 vaccines. But at the end of the day, if we are supposed to inform the decision makers on what vaccines to really order and what vaccines to distribute, we really need to see the full data set and the full publications for these 4 vaccines that are out there. In fact, even for clinical trials that are being conducted in the Philippines for these vaccines, we have to carefully read the investigators' brochures and the phase 1 and 2 studies to really be informed about the effect on participants in the phase 3 studies in the Philippines. So I don't think we should plunge into this right away. We should be open to what is out there, but study carefully. And the principles of grade apply here. And what are the principles of grade? We talked about participants, intervention, comparison, and outcome. Outcome to me is very important. Sometimes we talk about just the presence of antibodies, even though they are spike antibodies, which are supposed to be neutralizing, but we also want data on actual prevention of disease or mitigation of the severity of the disease. That's the importance of phase 3 trials. And even when the vaccine is distributed, we need phase 4 or post-marketing surveillance studies, because the adverse events may not be seen in even 30,000, phase 3 trial with 30,000 patients. We may not see it. So all throughout, we have to be vigilant and study the evidence. That's what the expert panels and the technology assessments are all about, so that the decision makers can be guided at the end of the day. It's not only evidence about vaccines we're talking about here. It's also evidence about what do the people think about the vaccine. Will they accept the vaccine? What's the evidence for communicating this well? So it's not just clinical trials we're talking about. I hope I answered your question, Jean.
Yes, ma'am. I'm very contented with the answer. Now I have 2 to 3 questions here in the queue board. From Dr. Bed Salido, thank you for the excellent lecture. Dr. Lansang, PSMID made and updated its COVID-19 guidelines during the pandemic, which were really helpful. The question is, do you recommend continuing on to complete the usual guideline process via the multidisciplinary consensus panel part?
I think that that should continue, because if you want to have a consensus, there's a consensus process after the first release of the or the first draft of the clinical practice guidelines. If you want practitioners and decision makers to accept the guidelines, you really need that consensus building process among various stakeholders. It can be rapidly done.
Thank you, Paul. And then the other question here, what can you say regards to TUUB, since some politicians are still promoting it, especially here in Cebu? I think it's more of the local intervention, non-pharmacologic intervention. You want to answer that?
Well, TUUB, the reports are anecdotal. And if you look at our 5-layered cake, anecdotal reports are really way down in the level of evidence. Of course, we have to be sensitive when we communicate this to lay persons. We cannot just say, oh, walang kwenta yan. We have to explain very well. But we know that the level of evidence for that is almost nil.
Okay, this is the last question. Which COVID vaccine has the best evidence so far?
I'll have to hold judgment on that, because right now, all I see are media stories. We don't have the data on hand. I don't know if anyone in the IATF has gotten hold of the data sets and the manuscripts for these vaccines. So no, sorry, I cannot answer without reading the evidence.
Okay, I think that's the last question, Paul. So again, thank you, and PSMID will always be grateful you're there as our pillar and our foundation, especially in evidence-based medicine. Thank you, Paul.
Thank you.
So at this point, we'll award the Certificate of Appreciation to Dr. Mary Ann Lansang for sharing her invaluable expertise as a resource speaker on the topic how to stay evidence-based in COVID-19, given this 42nd PSMID annual convention, signed by our scientific chair, Dr. Nina Berba, the overall chair of this annual convention, Dr. Victor Maginsay, and of course the current president of PSMID, Dr. Alejandria.
Thank you.
Thank you, ma'am.